Good afternoon, everybody. And it is a real privilege for me to welcome this galaxy of experts here on this evening that we have amalgamated here on behalf of the FOGSI Perinatology Committee to have a CME on two very important topics, that is Rhesus isoimmunization and recurrent pregnancy loss. And it is a very big privilege for us that the president of FOGSI 2122, Dr. Shanta Kumari ma'am, is here as the chief guest to inspire all of us and get the ball rolling for this particular program. At the very beginning, I would request Madam for permission to play the FOGSI theme video to start the evening, and then we can move on with the proceedings. Madam, with your permission, can I play the FOGSI theme video?
Dear friends, FOGSians and women of my country, I am Dr. Shanta Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a little girl, I told myself that I have to become something to make a difference. I always believed that if I desired something wholeheartedly, there is a positive force which makes it happen. And here I am, friends, standing in front of you as the 60th President of FOGSI, the 38,000 strong committed body of OB-GYNs taking care of women's health in our country. As a young girl, I realized that women play a key role in this world, just like Mother Nature or Stree Shakti as we revere it. It is a guiding force behind all forms of God's creation, and it's only a woman who can actually create a new life.
Hi, I'm Kareena Kapoor Khan and I'm so happy to be here with you, if only on video. Pregnancy is a beautiful experience and I have loved having my babies. I congratulate Dr. Shanta Kumari as taking over the 60th president of this eminent organization.
Stree Shakti is the embodiment of 5 elements: the sky, the air, the water, the earth and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, when a woman's health is neglected, it disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air and pesticide-free food.
Hi, I'm PV Sindhu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl in a nurtured and a safe environment.
Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of minimizing the female morbidity and mortality and fetal effects by mitigating the adverse impact of environment. My theme this year goes beyond FOGSI's commitment towards women's healthcare. FOGSI for all, always.
FOGSI for All is another inspiring campaign. What you do in this organization impacts the lives of all of us women in India.
And Dheera to stop violence against women. FOGSI for all, always will strive to make the girl a Sahasi with Swachhata, Samruddhi and Swasthya. To be Surakshit with Shakti to reach her full potential as a woman.
Dr. Shanta Kumari with the theme FOGSI for all always and Dheera Stop Violence Against Women will empower many girls. I firmly believe that only a safe girl, Surakshit Kanya, can grow into a healthy woman, Swasth Mahila.
Violence against women. I think it's a silent pandemic and I'm so happy to be a part of this campaign.
If any woman has a problem, where does she go to? Not to the police or court or the lawyers. She goes to her friendly OB-GYN, who is her first point of contact for help. So I have started Dheera, an initiative close to my heart, to sensitize our OB-GYNs, the police, the public and to partner with men to say no to violence against women.
I completely support her vision and mission as President FOGSI and also especially support her campaign, DIRA, Stop Violence Against Women.
A healthy environment is the core of a woman's health. A healthy woman makes a family happy and a strong nation. I, as the President of FOGSI, declare my commitment towards women's health and safety.
Thank you very much, ma'am, for that great vision that you have given us for this year of FOGSI activities. FOGSI for all, always, and DHIRA, Stop Violence Against Women. That has been a slogan that has taken the world by storm, because people have realized that not only clinics, but also extra clinical activities and social activities have become a core point in the care that we give our women. Dr. Shanta Kumari says, I want to make a difference with people who want to make a difference by doing things differently. And that's been her target throughout her mission in this journey of doing clinical work as well as social changes with these bodies. It's a pleasure to invite Shanta ma'am into this program, and I would request her to say a few words to inspire all of us.
Evening, everyone. Thank you, Dr. Chinmayi. And I think first we have to congratulate the chairperson of Perinatology Committee, Chinmayi, for starting off the first webinars for our committee. So let's hope that you'll do good work and keep the FOGSI's name flying high. And yeah, FOGSI for all always has been our motto always, and DHIRA, Stop Violence Against Women. We have here my teacher, Murli sir, and all my Jayam Kannan madam. I thought I saw Balamba madam, I think, but she's missing somewhere. And Bipin Pandit, our vice president, Dr. Madhuri Patel, my secretary general, Jayam Kannan madam, and so many other faculties with Vindhya, our Hyderabad Society president, and Dr. Krishna Kumari. Friends, I think the Perinatology Committee is very important because it actually reflects on the vision and mission of FOGSI. The vision and mission of FOGSI is to take care of women's health, and especially to work towards reducing the maternal morbidity and mortality and perinatal morbidity and mortality, which is so very vital for our country's progress. And yes, we know that we are now reaching 2030 towards the end of SDG goals. And let's hope that very soon we'll be able to achieve the target of SDG goals, reduce preventable maternal deaths and to reduce all possible maternal deaths. We were targeting less than 70 per 100,000, that is the maternal mortality rate. And we thought we were on the right track till now. And unfortunately, we have seen that the pandemic has put all our progress in many ways into a little, I think I should say, a setback. And that is the reason now with the pandemic on the go, I think now it is time for us all to actually get back to our vision and mission and try to see that we save our mothers. Unfortunately, we have seen some of our states like Kerala, which was supposed to be extremely good and a role model. Unfortunately, the ministry was telling that Kerala is having an increase in maternal mortality rates now. And Tamil Nadu, which was doing wonderfully well, also has seen a spurt in the maternal mortality. Whether the COVID pandemic or the infection per se, which is attributing to this maternal morbidity and mortality increase, or whether the lack of services because of this, all the effects of the pandemic, or is it the virus per se? Is it that COVID virus which is also responsible for increasing the maternal death is something of concern. So I think every one of us are trying to see how best we can reduce the maternal morbidity and mortality. I hope that we will be moving back to the times where our progress in reducing the maternal mortality was very good. We were doing extremely well, and that is, I think I should congratulate each and every FOGSI member who is working to save women and save mothers. It is your hard work which has actually helped in reducing the maternal mortality and morbidity. This is a very important factor. And the other area is, I think we have to look into try to reduce the stillbirth rate. Even stillbirth rate is something which none of us really thought much about. And now I think the focus should be there. We should see how best we can reduce the stillbirth incidence in our population. Unfortunately, we really don't have the perfect statistics also for the exact stillbirth rate prevalence in our FOGSI, I can say the hospitals and our practice. I think we as an organization have been evolving, and we are trying to see. The first target is we want to try to get the data. What is our stillbirth rate in the different institutes? So that's one thing which we are coming to you for, and hope we'll all get good cooperation from each and every member to get the data straight. And that will give us an idea, that will give us a chance to audit that data, and we will be able to actually find out what are the causes which are causing this increased stillbirth rates, and all the preventable causes we can target and try to reduce the burden of stillbirth. So these are some of the points I think which we need to ponder and see how we can take care of our mothers and our babies. I'm sure, of course, the topic for today's webinar will go on. Every webinar will have a different topic. We've got fantastic speakers, Professor Muralidhar Pai sir, who's there. He has gone all the way to Sikkim, but still it was made sure that he is there online, visible to everyone. And you got, I think, a lot of other faculty who will be dwelling on the subject of interest today, the Rhesus. But most important, I think we need to go back to our work of trying to save mothers. And please take care of yourselves. Though we know the COVID is on the decline, still it is there. So I think please take care of yourself, and that is the way forward. And let's hope that we'll be able to meet each other in person soon. So very soon, let's hope that we can reduce the onslaught of virtual webinars and go back to our bit of physical interactions, which means so much to us. And friends, I think again, I take this opportunity. We have on the 3rd and 4th September, we have the FOGSI FIGO physical hybrid event. A small hybrid hub is there in Hyderabad on the 3rd and 4th. And virtually all the others can join. We have got who is who of the global FIGO leadership who is taking part in this particular Congress. So I welcome all of you to join us for this FOGSI FIGO also. Very soon you will get the information. Dr. Madhuri joins me in welcoming you all to our Congress. And I'm sure that you will enjoy today's webinar, and all the best. I'm sure that this committee will be rolling out programs which will be affecting or trying to see how best we can reduce the morbidity and mortality. Just having a webinar, a scientific program, doesn't mean that we're going to talk anything and everything, because nowadays we know that the virtual platform is something which all of us know how the attendance will be. You know, many would have been just on or logged, and you may be seeing your patients, or you may be taking a nap, or you may be just cooking your dinner or something. But the idea is not that. The idea is to see that if we can engage our FOGSI members, to actually see if we can make a change. And I think that is what this virtual platform should help us. And thank you very much. And I have to congratulate our Subbu and team, TOG. They're always there with their virtual presence too. So looking forward to meeting all of you in person soon. Thank you.
Thank you so much, ma'am. Your words mean a lot to us. And bringing in the FOGSI FIGO program to Hyderabad as a hybrid hub is also going to be a very inspiring thing for all of us. And it's a pleasurable thing for us to announce that Madam has just been elected as the FIGO treasurer for the next term. So we look forward to many more things with you, and your advice regarding activities of the committee have been noted, ma'am. We will make sure we have programs up to the standard. I also have the pleasure today of inviting Madam Madhuri Patel, ma'am, who has taken time off, I'm sure, extremely busy schedule. And Madam is the Secretary General of FOGSI, and has held the posts of Deputy Secretary General, Treasurer, and Joint Secretary in the past. Always inspired by your extremely simple nature and your ability to run out things so efficiently without actually showing the stress on your face, ma'am. My heartiest welcome to this evening, and I really request you to say a few words to encourage us, ma'am.
Thank you, Dr. Chinmay. Am I audible?
Yes, ma'am. Yes.
Yeah. Thank you, Dr. Chinmay, for your kind and generous words. Respected Dr. Shanta Kumari, today's chief guest, and our most dynamic President FOGSI, Dr. Bipin Pandit, Guest of Honor, and our Vice President, Dr. Chinmaya Rath, Chairperson of Perinatology Committee FOGSI, Dr. Jayam Kanan, my dear friend, Dr. T. Vindhya, Professor Muralidhar Pai, Dr. Vandana Bansal, Dr. Krishna Kumari, Dr. Sangeeta Gupta, Dr. Sita Pal, Dr. Veena Panat, Dr. Vidhu Modgil, Dr. Shama Devadasan, Dr. Nisha Bhatia, and all my dear friends. Very good evening to all of you. At the outset, I would like to thank Dr. Shanta Kumari, Dr. BP, and Dr. Chinmaya for inviting me as guest of honor. It is an honor and great pleasure for me to be sharing the important academics with stalwarts and with all of you. As Dr. Shanta has already said that the FOGSI is the prestigious and the most vibrant and one of the largest OBGY organization in the world with 37,000 plus members and 262 member bodies. And she has already talked about the FOGSI mission that it supports and protects the OBGY practitioner of India. It encourages dissemination of education, knowledge, and research. FOGSI serves to advocate the cause of sexual and reproductive health and rights of the women. And the primary mission is reduction in maternal mortality and overall health of the woman, that is overall well-being of the woman. And of course, we also have a perinatology committee, and our mission is also to reduce the perinatal mortality and morbidity. We have FOGSI has two academic wings. One is ICOG and other one is JOGI. ICOG carries out all the college activities and they have a training and the certificate courses. And we have in ICOG membership as well as the fellowship. As far as journal is concerned, it is a bi-monthly issue, and that means the 6 issues in a year. And every time when we release the issue, we send the SMS to all 37,500 plus members, and with the link. So on their smartphone, when they click the link, you get whole journal of that issue. And I would like to mention that during this COVID pandemic, we have also come out with the e-journals. And I would like to feel very happy to say that on our website, that is on www.fogsi.org and JOGI website, we have our issues from 1950 onwards. So anybody can access, what we have written, what we have done, and can take advantage of that. Then FOGSI distributes the journal to all 37,500 plus members all over India, free of cost. But because of this COVID pandemic, we could not print, but now the situation are becoming better and better, and we will start printing the journal and you will all get the journal. We have 27 committees and chairs, and Dr. Chinmaya has recently taken over as a committee chair of Perinatology Committee, FOGSI, and this is her first webinar. So Chinmaya, I'm very happy that I'm sharing with you your first webinar, and she has selected very good topics. But I have to tell Shanta that we have I've seen something in the group that we should have some recent advances in this perinatology. So I feel that I'm very confident that Chinmaya, with her persistent and consistent efforts, will come out with a new vision in Perinatology Committee. And Dr. Chinmaya, we all are with you, and I wish you best luck. Then, the hematological disease of the newborn was first described in the medical literature in 1609, when it was diagnosed in one of the French housewives. In 1932, Diamond and Culling described the mutual relationship of fetal hydrops, jaundice, anemia, and erythroblastosis, which was later called as fetal erythroblastosis. Now, with the majority of our women delivering in the institute, so the diagnosis and the prevention of the RH isoimmunization has become very easy. At the same time, with the advance in the treatment of the RH isoimmunization, the perinatal mortality and morbidity has reduced considerably. So we are fortunate to have Professor Muralidhar Pai and Dr. Vandana Bansal, who are the golden teachers with captivating oratory skill, and are going to enlighten us on RH incompatibility, prevention and management. Then the other topic of today is recurrent pregnancy loss is another Very, very important topic, and we are concerned because nowadays also we get so many patients with recurrent pregnancy loss, and many times we can't help them. So it is very important because 50% of the causes are unexplained. So it is physically and emotionally very taxing for the couples. So we have galaxy of eminent panelists and moderators. They will enlighten us on these topics, which will enable us to elevate the suffering of our women. Knowledge is the key to success. Hence, my sincere congratulations to Dr. Shanta, Dr. BP, Dr. Chinmaya, and of course, Subbu for the most apt webinar. As a Secretary General, I would take the opportunity to say, if you require any assistance in FOGSI, you can contact me anytime. My contact details are on the www.fogsi.org, and I'll be very happy to serve you all. Before I end, let me quote Albert Einstein. Education is not the learning of facts. Education is not the learning of facts, but it is training of mind to think. So thank you once again.
Thank you very much, ma'am, for those really wonderful words. And like you said, education is not just learning of facts, but training the mind to think. And I think you've been a teacher for so long and you understand that we really need to drive in some facts again and again. So it's very nice. And I really most humbly accept your words, and I'll hope to keep your confidence in the activities of the Perinatology Committee. Thank you so much for being with us, ma'am. With that, I would like to invite my Vice President for this year in charge, Dr. Bipin Pandit, sir, who's been a strong wall of support for all our activities. And sir doesn't say much, but I'm sure he holds a lot of vision in how things have to be planned and how they have to be conducted. So without much ado, sir, I would request you to please give a few words before we start on the academic program.
Thank you, Chinmay, for your kind words. It's a great pleasure to be with all of you for your first venture, and all the best and congratulations for you and the Perinatology Committee and your team. Madam Dr. Shanta Kumari, our President, Dr. Madhuri Patel, you Chinmay Ratha, Dr. Murlidhar Pai, Vandana Mansal, and all the great panelists. It's a great pleasure to be with you in this Perinatology Committee first webinar, where you have chosen very good topics. Both are very important. Our day-to-day practice, recurrent pregnancy loss, of course, as Dr. Madhuri said, very, very important in our practice. And RH isoimmunization is also. The maternal antibodies produced in response to the paternity-derived D-antigen on fetal red blood cells are the leading cause for this severe hemolytic disease. And with the advances going on every time, today we are looking at, it's a totally preventable problem, RH isoimmunization, and we are trying to use anti-RHD as a preventable measure also for affected patients. So it's a very nice topic, and I'm looking forward listening to you all. And thank you very much for giving me this opportunity. Thank you. All the best.
Thank you so much, sir. We will just begin our program, and before we actually begin, we want to have a little Guru Vandana so that we get the blessings of the Almighty also. And
Gurur Brahma, Gurur Vishnu, Gurur Devo Maheshwara, Gurur Sakshat Parabrahma, Tasmai Shri Guruve Namaha.
with that, I hand over to Dr. Nisha. She is one of our young guns from Hyderabad, and she's an assistant professor in the Apollo Institute of Medical Science and Research. Dr. Nisha is the master of ceremony for today evening. And like this is our first program, this is Nisha's first MC job. So I request all the seniors to please bless her that she will go far onto this. Nisha, can you please take over?
Very good evening to all of you. and I welcome you all for the first academic session of FOGSI's Perinatology Committee, that is on RH isoimmunization and recurrent pregnancy loss. So prevention is better than cure, and this stands true, especially in the case of RH isoimmunization, and will be highlighted in the talks today. But before that, let's have a short quiz for the audience, the answers of which I will share at the end of the session. Ma'am, can you share the quiz?
Yes. Session, will you just put on the quiz? We have just designed a short multiple choice questions. Yeah, go on.
So it's a poll which it's a short quiz with multiple choice questions. It's like a poll, so you'll have to give the answers immediately. There is a time limit, so the questions will disappear fast. So just look at the quiz and start answering.
There are only 5 questions. This is just to get your baseline knowledge in checked, and also for you to know what you have to pay attention when the experts are going to speak. Can we have the poll, please, Session?
The first question is, which of the following is not a potentially sensitizing event for the development of Rhesus isoimmunization in pregnancy? Is it A, ERPC after miscarriage, B, ectopic pregnancy, painless vaginal spotting less than 12 weeks, or an intrauterine death?
Next.
So please give your answers quickly because the questions will disappear. Coming to the second question. When should an unsensitized RH negative woman be screened in pregnancy with ICT? The options are A, at booking, B, third trimester only, C, priming gravida does not require screening, D, at the time of any sensitizing event only. So please be quick and give your answers because the questions will go rolling.
The poll has appeared, so all of you should attempt the answers. Yeah.
Please attempt the answers. Coming to the next question, what is true regarding anti-T prophylaxis? The first option is effective only when you give within 72 hours of a sensitizing event, can be given up to 4 months of the sensitizing event, can be given up to 4 weeks of sensitizing event, or need not be given if missed immediately. Coming to the next question. Which fetal vessel should be examined for monitoring isoimmunized pregnancy? Is it A, umbilical artery PI, B, ductus venosus PI, aortic isthmus A wave, or middle cerebral artery peak systolic velocity? So please keep giving your answers. Coming to the last question. Which blood group should be used for intrauterine blood transfusion? A, leukodepleted mother's blood group, fetal B, fetal blood group, C, leukodepleted O negative blood group, or D, leukodepleted father's blood. So with this, we come to the end of the poll. The answers of this quiz will be shared at the end of this. So I now request Dr. Chinmay ma'am to introduce the chairpersons for today's session, a talk on RH isoimmunization. Over to you, ma'am.
Thank you, Nisha. And I hope the audience has got engaged with that quiz and they will be looking forward to the answers in the talks that come. With that, I have the very pleasant duty of calling in our expert chairpersons. And I'm really humbled that Jayam ma'am has accepted to be the chairperson on this first webinar of the Perinatology Committee. Madam is a great teacher, and like it said about great teachers, a great teacher takes your hand, opens your mind, and then touches your heart. She is an excellent person, a great human being, and the only Indian to have received the Distinguished Service Medal by the RCOG in 2018, and I was lucky to be witnessing that. And apart from a long retinue menu of achievements that she has had, including medals and medals of gold in in her academic career. She has been a very, very inspiring FOGSian and somebody we all look up to. Welcome, ma'am, to this evening. And our second chairperson is Dr. Vindhya. She is a very, very dear senior to us from the Hyderabad Society, currently our president of the Hyderabad Society, and someone who has a lot of achievements in the clinical front and in academics, where she was the member of the ICOG Governing Council and has taken part in almost all conferences that we have had in the aegis of the Hyderabad Society in Hyderabad, and somebody who really touches you with her simplicity in spite of her greatness. Thank you so much, chairpersons, for being here. Now I hand over the session to you.
Thank you very much, Dr. Chinmayi, for your excellent conduct of this first, the best step in your next step in life, that is being a FOGSI chairperson under the leadership of your own state person from Telangana, the great Dr. Shanta Kumari. And today, I am really privileged to introduce Dr. Muralidhar Pai. Can I have his slide on?
Yes, ma'am.
His CV. He is a teacher of teachers. Our teacher presently is the great Dr. Shanta Kumari. To her, Dr. Muralidhar Pai has been the teacher. Manipal has gifted to FOGSI Padma Rao, Pratap Kumar, and Pai Muralidhar. I'll keep the three doyens from that place. And he has so many lectures, so many publications, and he has authored so many books, and he has also been the best in every part of his life, right from his student days to the teacher days. But now he is showing his ability as a great administrator sitting at Sikkim Institute of Manipal University. He is a great orator with a great ability, can deliberate on any subject that you give to him, and he can do the best of his teaching to the student as well as to the great scholars also. I have shared the platform with him as a faculty many times, and his talk today, all the delegates, please note that he is going to literally sensitize you on the anti-TB prophylaxis at the appropriate sensitizing events and more. Over to Dr. Muralidhar Pai for his excellent deliberation, which I am waiting for.
Thank you very much, ma'am. So, it's always a pleasure to visit Hyderabad, whether physically or virtually. Respected President of FOGSI, Dr. Shanta Kumari, respected Vice President Vipin Pandit, respected General Secretary Dr. Madhuri Patil, and dear Chairperson of Perinatology Committee Chinmayi Ratha, Chairpersons of the day today, Dr. Jayam Kannan and Dr. Vindhya. I am really humbled by the love and affection all of you are showering on me and inviting me to give lectures. It is a great opportunity for me to learn, even though now I have come out of obstetrics and gynecology department proper as a dean here. These webinars are keeping me on my toes to learn new things, update myself every time. And today I'm really happy to be the first speaker of the first webinar that is going out from the Perinatology Committee this year. And I must congratulate both Chinmayi Ratha and her selection, that is Dr. Nisha. They have done a wonderful job. I can make out right in the beginning, they have done something like a pre-test. And I'm happy that I'm going to answer those questions in my talk. But actually, believe us that we didn't do any match fixing. I don't know how they read my mind. I'm actually addressing all the questions they have put up there. So without much ado, I would like to straight away jump into the topic. RH isoimmunization. This was my thesis topic as well when I was a PG, and it is very, very close to my heart. As Dr. Madhuri Madam said, once upon a time, this was a sure cause of death of the fetus. And as Dr. Shanta said, we need to not only reduce the maternal mortality, but we must also reduce the stillbirths. These are the two indicators that would talk about the health of a country and also the progress of a country. So towards that end, RH isoimmunization is a problem which can be easily prevented, as told by Dr. Vipin Pandit. And that's what I'm going to highlight on today. That is sensitizing events in pregnancy and appropriate use of anti-D. I'll be talking on prevention and prevalence, sensitization and immunization, then sensitizing events, when to give anti-D, how much to give, and are there any complications? So first, prevention and prevalence. Yes, prevention is better than cure. And this particular disease has shown that very, very nicely. Avoiding mismatched blood transfusion, as simple as that, can prevent isoimmunization. Minimizing feto-maternal hemorrhage. Of course, the word used minimizing because some amount of feto-maternal hemorrhage will go on, which we cannot prevent. But definitely by taking measures, we can minimize it. Preventing active immunization. Even with all our efforts, if some blood goes from the fetus to the mother, we should have a method of preventing active immunization. And that's been possible by administering anti-D immunoglobulin to the mother. Before anti-D, it was 16%. But after routine postnatal anti-D-Ig, it came down to 2%. And the good news is, after routine antenatal anti-D-Ig, it has come down to almost negligible level of 0.17 to 0.28%. So this is the success story of anti-D prevention. Mortality associated with hemolytic disease of newborn also reduced from 46 per 100,000 births to 1.6 per 100,000 births. Now I talk a little bit about what is this sensitization and immunization with a graphic. The immunocompetent cells of the mother, when they are first exposed to the fetal positive cells, nothing happens actually. But after 1 week, the cell gets sensitized. I am showing it in the change of color. Now this cell is ready. After the second exposure, they produce antibodies in 6 weeks to 6 months. 6 weeks to 6 months. That's exactly why even the first pregnancy may not be spared. Suppose the mother is exposed to the fetal cells very early in pregnancy, let's say around 15 weeks. Within 6 weeks to 6 months, that is another 6 weeks to 24 weeks, she can produce antibodies. And these antibodies can cross over and affect the baby in the very first pregnancy. But subsequent exposures, the antibodies will go and destroy the fetal red cells and causes hemolytic disease of the newborn. This is sensitization and immunization. Now, what will anti-D-Ig do? The anti-D-Ig neutralizes any RHD positive antigens that may have entered the mother's blood. So this will go and bind that, and that will neutralize, so that mother will not get sensitized. She doesn't see these positive antigens at all. So there is no question of her producing antibodies. So this is the very simple way we can prevent mother from producing antibodies against her own possible babies. Having understood this, let's now go to the main part of the topic, that is, what are the sensitizing events? Potentially sensitizing events, what we call PSE, and this has got grade 1C evidence: antepartum hemorrhage. Antepartum hemorrhage due to any reason, placenta previa, or it could be due to accidental hemorrhage, or whole lot of causes of antepartum hemorrhage are potentially sensitizing events, because at this time the fetal cells enter into mother and mother gets sensitized, and eventually she will produce antibodies. External cephalic version of the fetus. Yes, some amount of separation of the placenta may occur at this time without our knowledge, and the blood can escape into the mother. Abdominal trauma, sharp or blunt, closed or open. Intrauterine death and stillbirth. Again here, once the death occurs, there is separation of the placenta and some amount of admixture of the blood. After all, the human placenta is hemo. That's why there is always some amount of admixture of the blood. At the time of delivery, this is one thing which is very, very important, and this is one area where we can minimize the feto-maternal bleeding, whether it is normal delivery, instrumental delivery, or cesarean delivery. Intraoperative cell salvage. Sometimes when blood is short, we may try to use mother's own blood and sieve it and use it, but that would have been mixed with the fetal cells. Spontaneous miscarriage with intervention. I have highlighted the word with intervention. That means if you have done curettage, if you have done suction evacuation. Therapeutic termination of pregnancy, whether surgical or medical, because there is contraction of the uterine musculature in medical termination of pregnancy, and in surgical, you are literally curating and doing some intervention. Ectopic and molar pregnancy. Yes, there will be some amount of intervention. So anti-D should be given regardless of method of management, medical or surgical. Threatened miscarriage, repeated and associated with cramps. Now, underline the word cramps. Invasive prenatal diagnosis, amniocentesis, chordocentesis, CVS, and intrauterine procedures such as insertion of shunts, embryo reduction. With the advancement in perinatal fetal medicine, these are become very common procedures. So all of them are sensitizing events and definitely ask for anti-D. Now I come to the most important thing, when to give. Within 72 hours after delivery. Now this answers the question, one of the questions in the quiz. If baby is positive, but DCT is negative, the asterisk is mainly telling if RADP, I'm going to talk what it is in the next slide, is given, that is routine antenatal anti-D is given, the DCT may be falsely positive, especially if it is given within 6 weeks. Still, you can give anti-D to the mother. If ICT is negative, and if routine antenatal anti-D prophylaxis has been given, whether it is one dose, 28 to 30 weeks, and some centers give 2 doses, 28 and 34 weeks. So this is what is called routine anti-D. One is postnatal within 72 hours. Another one is antenatal, which is given around 28 weeks. Now, when to give RAD? It should be regarded as separate entity and administered regardless of and in addition to any anti-DIG that may have been given for a potentially sensitizing event. Let me clarify this. Suppose there was some intrauterine procedure you did at around 14 weeks, 16 weeks, let's say amniocentesis you did. That is a sensitizing event. You would have given anti-D. In spite of that, come 28 weeks, you must give another anti-D that is called routine antenatal anti-D prophylaxis. I hope I am clear. I will repeat the words regardless of and in addition to any anti-D may have been given for a potentially sensitizing event. Now I come to potentially sensitizing events. When to give? As soon as possible and always within 72 hours, like we give after delivery. After all, delivery is also a sensitizing event. Some protection may be offered if anti-DIG is given up to 10 days after PSC, but not after that. What about spontaneous miscarriage before 12 weeks? This slide will answer the first quiz question. If it is complete miscarriage, confirmed by scan, uterus not instrumented, please note the word not instrumented, anti-DIG is not necessary because the risk of fetal hemorrhage and maternal exposure to maternal exposure to D antigen is negligible. What it means is if you have not meddled with. Same for mild, painless vaginal bleeding before 12 weeks and none after that. This is a straightforward answer to the first question. If the miscarriage or vaginal bleeding has been painless, no contractions, no manipulation, no instrumentation, and no bleeding after that, no need of anti-D because there is no admixture of the fetal blood. I now come to how much to give. Ideally, testing is recommended to quantify the size of fetal hemorrhage after delivery, but usually we don't do that after all deliveries. An anticoagulated blood is taken after 30 to 45 minutes following delivery for this purpose. If the result indicates a very large fetal hemorrhage, flow cytometry to be used to quantify the amount of the fetal hemorrhage accurately. We did a thesis in Manipal. For that purpose, we use this flow cytometry. Otherwise, routinely, it is not done. If there is a large fetal hemorrhage, you can suspect this in cases of big placenta, for example, twins and gestational diabetes and anemia. 500 international units of anti-D will neutralize a fetal hemorrhage up to 4 ml, which is normal. That's what happens most of the cases of the RH isoimmunized mothers, 99% of the women. For each ml above 4 ml, you have to give additional 125 microgram of anti-D. In large fetal hemorrhage, that is more than 100 ml, a suitable preparation of IV anti-D should be considered. The first two are IM, the last one is IV. The quantity is commercially available injections are in 50 microgram, it is 250 IU. It takes care of around 2.5 ml, easy to remember. Just divide by 10 or maybe 100. And 300 microgram contains 1500 IU. IM or IV preparations are available. It takes care of up to 15 ml. I told you in the previous slide, 500 IU will take care of 4 ml of blood, which is the usual fetal metal hemorrhage in 99% of the cases. So this 300 microgram, which contains 1500 IU, will take care up to 15 ml, again divided by 100, easy way of understanding this. So should be good enough for most of the cases. IM preparation should not be given as IV in case you anticipate massive fetal metal hemorrhage where you have to give very, very heavy doses, then IV preparation is to be used, but don't substitute IV with the IM preparation. Minimum recommended doses, if it is less than 12 plus weeks, for example, ectopic, molars, therapeutic termination, repeated bleeding with cramps, 250 IU is good enough. But 12 to 20 weeks, 250 should be given if it is just a sensitizing event. You should test for FMH other cases, but in these cases not required. For continual uterine bleeding, 250 IU should be given at a minimum of 6 weekly interval. If the bleeding repeats, every 6 weeks you must give this. More than 20 weeks of gestation, you must consider 500 IU, that is 300 microgram mcg. For continual uterine bleeding of same sensitizing event, 500 IU to be given at a minimum of 6 weeks interval, same recommendation. But if there is a new symptom occurs, suggestive of additional sensitizing event, then additional 500 dose to be given at every time. Let me explain this. After 20 weeks, you just give 500 IU. And if you think that the same sensitizing event, that is a vaginal bleeding occurring, you give every 6 weeks 500 ml. But you do additional procedure, for example, or if there is additional bleeding, antepartum hemorrhage, you give additional 500 IU. Estimation of FMH should be done at 2 weekly intervals in these situations, but less than 20 weeks, it is not required. Additional anti-D should be given to cover volume of FMH, as I told earlier. If anti-D found in serum, you must take history with regards to receiving anti-D earlier, investigate whether this is immune or passive. If no clear conclusion can be reached as to the origin of anti-D, then it should be considered. As far as intrauterine death is concerned, our appropriate dose would be 500 IU. Within 72 hours of diagnosis of IUD, irrespective of the time of subsequent delivery. What about intraoperative cell salvage? ICT negative, cord blood is positive or unknown, and minimum dose is 1500 IU, which is nothing but our available 300 mcg. FMH estimated every 30 to 45 minutes after reinfusion. Additional anti-D is given accordingly. Transfusion of Rh positive blood by mistake. If you have given platelets, just give 250 IU, subcutaneous or IV, to cover up to 5 adult doses of platelets given within 6 weeks. If you have given PRBC, up to 500 ml, 1500 IU. But if you have given more than 15 ml in multiples of 1500 IU, preferably given in IV because you are giving a large dose. If you have given more than 1 unit, better consider exchange transfusion. The quantitation of D positive red cells should be performed by flow cytometry after 48 hours of IV dose, 72 hours of IM dose. Good practice point would be auditable records of issue and administration should be maintained to allow full traceability of anti-D IG. The last part of the talk is the complications. Mild short-term allergic reactions are seen like fever, chills, rash, swelling of face, lips and tongues, chest tightness, rapid breathing, and confusion. Very small risk that an infection could be transferred through the injection. I remember once there was a batch which was withdrawn by the companies. Otherwise, most of them are tested, and now it is very, very safe. Benefits of preventing sensitization far outweigh these small risks. So just give it off. While receiving anti-D, however, avoid live vaccines for 3 months, like measles, mumps, rubella, rotavirus, typhoid, yellow fever, varicella zoster, and influenza. Vaccine may not work as well during this time, may not protect fully from the disease. Then finally, a small talk on cell-free fetal DNA, one slide. 40% negative women receive anti-D unnecessarily, especially when you give it antenatally. Agreed. But doing this cell-free DNA from maternal blood 16 to 28 weeks detects fetal D type with accuracy of only 96%, not 100%. There may be false negative of 0.08 to 0.16. So my recommendation is select whichever is cheaper. If you think detecting fetal blood group by doing cell-free DNA is cheaper, go ahead, but it is not 100%. If anti-D is cheaper, give anti-D. Doesn't matter, even if it was not necessary, but that is only a retrospective diagnosis after the baby is born. So to conclude, sum and substance of what I said is, give anti-D within 72 hours after delivery. As far as antenatal anti-D is concerned, 1 dose is good enough at 28 weeks, irrespective of the doses that you would have given for sensitizing events earlier. But after sensitizing events, irrespective of gestational age and method of management, repeat every 6 weeks if there is continuation or occurrence of fresh event. Less than 20 weeks, it's only 250 IU. More than 20 weeks, 500 IU. Either you can go for 100 mcg or 300 mcg. There is no need to give anti-D if the bleeding occurs before 12 weeks without any cramps, or if it doesn't repeat afterwards. Thank you very much.
Thank you, Dr. Pai, for this highlighted messages with evidence-based medicine on level 1C evidence for sensitizing events and for dating with RH prophylaxis once or twice and redating with special events. And you have put up the level 1B evidence for the fetal-maternal hemorrhage detection, dosing, route of giving very specifically notified, and with grade 2C evidence for the redosing. I am very happy to note that you have made it at the last very clear that the cell-free DNA test may be scientific, academic, research-oriented. But is it patient-oriented is $1 million purchase. Because even if your patient falls among one of the 4%, that means you are a big loss in her life. So it's a topic not to be memorized, as he has put so many events, needs to be refreshed then and there. So Chinmayi will bring this topic back again and again in perinatology in a different shape, and calling people like Muralidhar Pai with who can answer in any different form for the events. Thank you very much. Over to the organizer for questions or for the next event.
I think we'll have the next talk. So I request Vindhya ma'am to introduce the next speaker. And then I think we'll have questions at the end of the sessions. We're collecting questions from the audience.
Okay.
Thank you, Chinmayi. I think Murli was very clear. And then, as always, he is very clear, crisp, and about the dose, everything. And he makes everything very clear. He makes everything very clear. And that is the beauty of his talks. So now coming to Dr. Vandana Bansal. She is an associate professor in Nauroji Wadia Maternity Hospital, and she's the director of Surya Fetal Medical Medicine Center, Mumbai. And she specialized in fetal medicine, and she's the first one to get the postdoctoral fellow, that is FNB in India, qualified in the field of high-risk pregnancy. And she has 25 years of experience, and 18 years as fetal medicine. And she served as a chairperson of Fetal Medicine Committee in 2017 and 2019 at FOGSI. And she was the National Coordinator Imaging Science Committee in FOGSI, 2018 to 19. And she is a member managing committee MOGS. And she is a member of Ethics Committee, a clinical expert in Vadia Hospital. Welcome, Dr. Vandana Bansal.
Very good afternoon, and thank you, Dr. Vindhya, for introducing myself. I'll share my screen. I think you'll have to unshare your screen to get me on. Yes. Yeah. So while I'm opening up my slides, I want to bring about, just want to make a comment on how important RH isoimmunization is, that in spite of sensitization and the anti-D that is available, we still get a lot of these cases of isoimmunized pregnancies. As much as today only, I had a triplet pregnancy, all of them anemic at 28 weeks of gestation, and the patient says, okay, transfuse to all my triplets so that I have 3 babies born with Rh negative isoimmunized pregnancy. So in spite of all this anti-D prophylaxis, which was started in RCOG, in 2011, we have those guidelines, we still get a lot of these sensitized mother. And so this topic is so important to us. And as obstetrician and as fetal medicine, we need to actually understand how do we manage them so that they don't come to us in a state of hydrops. So I go on with my topic. And you all know hydrops fetalis is a dreaded event in the life. Not only for this pregnancy, but her every next pregnancy and all her future obstetrics is going to be bad if one of them comes up as hydrops of immune cause. And this condition in which fetus becomes edematous often dies in utero because of anemia. And it is also an example of a disease where we have been able to find out pathogenesis, found a treatment for it, and also have found out prophylaxis for this in the past 50 years. And this cannot be underestimated. The conquest has been brought about by all these big stalwarts, Phillips, Levin, Landsteiner, who looked at Rh factor. Liley, we know about his Liley's chart as well as for his intrauterine transfusion, and Charles Rodak for the first intravascular transfusion done with fetoscopy. And now we also, we discuss so often about Mary et al., who started this non-invasive assessment of fetal anemia, and which has changed our looking at RH isoimmunization. And also, let's not talk about Frida and Gorman, which has already been spoken about. And they have, with the use of anti-D, the risk of isoimmunization has reduced from 16%, as what Sir said, Dr. Pai, to less than 1%. But this less than 1% is what I am going to talk about in a few minutes that we have. So I don't want to go into the background. Yes, India has got 5 to 10% Rh negative mothers, but comparing to that and the neonatal deaths which occur in South Asia and Afghanistan, and you would understand that the stillbirth from Rh disease is significant in our side of the population. And we are understanding all this and start referring them at the right time. So here I start off with the pathophysiology. So if you have a mother which is negative with a baby which is positive, as Sir said, the fetal RBCs cross placenta only in about 5% of cases in the first trimester because there is a placental barrier. But still, by the 3rd trimester, the feto-maternal bleed is significant, and it is always at the time of delivery. So 100% there will be a feto-maternal bleed which happens, but not all mothers will get sensitized. So only about 15% of all these mothers which are negative with the baby which is positive will get sensitized. And this 15% sensitization we reduce down to less than 1% by the use of anti-D. So now once we have this mother who has got fetal cells and there is production of these antibodies, so these IgG antibodies will take time, so 6 weeks to 6 months. So if it is happening at the time of delivery, it will usually not affect the first pregnancy, except if it happens the sensitization in the first trimester, but most of the time it doesn't affect the first pregnancy. But these IgG antibodies then remain in the mother's circulation lifelong. So this now mother becomes a sensitized mother which has got antibodies which will act on the next pregnancy that there is. So the next pregnancy, these antibodies which are already present in the mother's circulation cross the placenta. They are IgG antibodies, so they cross the placenta easily, and they will go to the RBCs, which are positive antigen RBCs, and cause hemolysis and anemia. So the concept is that we are looking on ultrasound for this anemia, and so we are looking at increased cardiac output, increased velocity in the brain, extramedullary hematopoiesis, and then at high drops. So everything that we are looking at is looking at anemia. So anemia by hyperdynamic circulation, you see the portal vein gets dilated and the ducts become portal vein sawtooth appearance. Cardiomegaly, because there's increased output and so the heart pumps more and so it becomes enlarged. There could be a tricuspid regurgitation, there could be pericardial effusion as well. So again, anemia looking at ultrasound. Then the placenta will become enlarged and so you will have a placentomegaly and polyhydramnios, again because of hyperdynamic circulation. So these are all beam mode appearances of fetal anemia, and then they can be hepatomegaly and splenomegaly because of extramedullary hematopoiesis. So the physiology of the baby is changing. So you have got hepatomegaly and which you pick up, but you cannot actually correlate with the amount of hematocrit. You will know there is hepatomegaly, but you can't know what is the hemoglobin of this baby. And finally, the last stage, the end stage, is the hydrops that develops. So this will develop when the hemoglobin comes down to 5 gram per cent. The baby's hemoglobin is usually 15. So when it comes down to 1/3, you will start showing these features. When most of the time patients are sent to us, and this is the time the results are the poorest. So you'll see ascites, you'll see scalp edema, you can see pericardial effusion, pleural effusion. So now the baby has gone cardiac failure because of anemia. So how do we pick them up early is to the babies. Till now, all things were beam mode, and now we are looking at the velocity. And so, Mary et al. Looked at middle cerebral artery peak systolic velocity. So there is dynamic circulation velocity is fast anemic baby, and so you will measure the velocity, and this is the practice changing discovery in RH isoimmunization, if I can call it, because when I started off, we used to do amniocentesis for all, and now we are not doing amniocentesis at all for determining when to do a transfusion. So MCA velocity, how do you look at the middle cell artery from
Dr. Vandana, there's some audio interruption. Sorry, Dr. Vandana, some audio interruption. I think you can just switch off your video. Maybe your voice will come better. Because
yeah. Is it better now? I
yeah,
can
better,
come here.
Better now.
Yeah. So
yes,
you need to look better now.
Yes.
Yeah. So we look at the velocity of the middle cerebral artery with the velocity angle dependent. So you have to have it less than 15 degrees. And these are plotted on these charts. So they are charts which are either you put them on these metal charts, could calculate the MOM by various softwares. And so if this MOM is more than 1.5 MOM, it would mean that becomes severely anemic. So it is an most accurate non-invasive method of diagnosing with a sensitivity of 100%. 100% means maybe which is I will be able to pick it up. On the other probably I may increase my false positive rates by 12%. So I may overdiagnose someone, but definitely I am not going to miss out on any patient. And is the quality of a middle. And this will tell us about the data, which I said most other B mode methods are not going to tell me. So this spectrophotometry amniotic fluid to look at optical density is now obsolete, and we have stopped doing it for the past maybe about 20 years. So we actually looked at our trends of what we did in the first 7 years and the second 7 years after the availability of MCA-PSV. And we have this publication which says that our number of procedures have reduced down per person. So earlier when we used to do amniocentesis, it was 4 procedure per patient has reduced down to 2, and our survival results have become better, and they are much better than what is there now shown in this picture. So in an Rh negative non-immunized mother, we will do an ICT at booking visit and repeat at 28 weeks. If it is negative, we give an anti-D and no further testing to be done, and anti-D post-delivery within 72 hours. But if it is anytime the ICT becomes positive, so this becomes our first Rh immunized pregnancy. So she has no previous history and she has become ICT positive. You will look at the titers that remain in critical, which will be different for different labs, and you will monitor the titers every 4 weekly. So only if there is no previous history, the titers may be useful, where you can monitor the titers every 4 weekly till they reach value when you will have to start measuring the MCA velocity. So if it is the first immunized, no previous history, the need for transfusion will be very less. So only in about 10% of cases you may actually require transfusion. But if there is a previous history, so the history is important. If you have a previous child with IUFD or anemic or had hydrops or had icterus, then the chance of requiring transfusion will be 80%. So that is the importance, that if you have this first ICT positive, you can monitor by titers. The chance of requirement of transfusion is less. But if it is a previously affected pregnancy, the titers are not going to help us, and we will have to only follow up the middle cerebral artery velocity. So if it is a previously affected isoimmunized pregnancy, antibodies are not going to help us. They will just help us in telling, yes, this is an immunized pregnancy. You will need to monitor them by MCA-PSV, which we can start at 18 weeks of gestation. And we can follow them up till about 35 weeks or whenever we require transfusion. So a gist of what I have spoken: if it is a first affected pregnancy, do antibodies every 4 weeks. If they remain below the critical level, you deliver at 38 weeks. If they go above critical values, you will need to now start looking at middle cerebral artery velocity. But if it is a previously affected baby, then you will only follow them up with an MCA-PSV, and when it reaches 1.5 MOM, you plan an intrauterine transfusion. So you don't do transfusion for everybody who is isoimmunized. So only once the hematocrit reaches less than 30%, or I see high drops, so that means if my MCA value is more than 1.5 mom, is when I am going to plan a transfusion for these babies. So before that, you can just continue to monitor them with an MCA-PSV. So you could do intravascular, intraperitoneal, and intracardiac. But basically, the most important is intravascular. So you're actually only correcting the anemia. You're not reversing the problem which is there. So the antibodies will again cause anemia, and you need to keep the then intraperitoneal very infrequently do this, and when the anemia becomes severe, even less than 8 weeks, or the cause is not available for us, we might want intraperitoneal, but it's not a very good method. Least effective if there is hydrops which is present. So intravascular is what we routinely do. So if I do 100, it will be only intraperitoneal, as are intravascular. You may go in the cord insertion, you may do it in the intrahepatic or loop of cord, and there are charts for looking at how you calculate this volumes, and also available on the internet. So I just brought it out for people to know. So here I start off how I will do a transfusion. So first I need to paralyze the baby. So how do we paralyze is to give them pancuronium or a vecuronium, 0.3 milligrams. Be intramuscular it is given. So for about 2 hours, the baby is going to be quiet. And how do we reverse it? It will get reversed through the placenta into the circulation. So in 2 hours time, the baby will start moving and the anesthesia effect would have gone. So it's a 3D imagination of where we are going. So you need to look at where the cord is, which is moving in through the placenta into the vein. So we go into the vein, not into the artery. The veins
Again, your audio is giving a problem, Dr. Vandana.
is the bigger one.
Ma'am, you can switch off your video.
I've switched off every.
No, your own video if you switch it off.
How will I see?
Yeah, now you can see.
Okay. So intrauterine transfusion, you will do a hematocrit. At the same time, look at the blood. So while you're doing this, you will also need to continue to look at the heart of the baby, because there could be a chance of a overload bradycardia, which you will need to. So you can see the echogenic turbulence that you see here while we are doing the transfusion. So when we don't have a placental cord insertion, then we could go into the hepatic portal vein. And this may be a good method because the chance of hematomas are less in this. But here you will have to go in with a jab, because the baby can move away and you cannot move once you are in the liver. So here you can see the needle going into the liver, into the portal vein, and then you can start off the transfusions. This is into a hepatic portal vein, and you can see that echoes that can be seen. There is a little pain probably the baby has, so there is hyperventilation. So I go complication is about 1 to 3%, not too great. And once we've done the transfusion, then we need to monitor. So how do we? One, I will take out the cord blood at the end of the transfusion and see what the hematocrit is. It will keep falling by 1% per day. And second is, we would also look at the MCA. So post-transfusion, one I will do after 24 hours, and then I will follow it up every 1 week or 2 weeks. And once the velocity again goes up, I am ready for the next transfusion. So this is how we would do. So our last transfusion is going to be at around 35 weeks of gestation, so that we can deliver around 37 completed weeks of gestation, give steroids, the mode of delivery is not going to change. So while I have my baby ready for delivery, I need to have my NICU also ready, because what treatment I have given, the baby will also require exchange transfusion, may require top up, and definitely require phototherapy. The blood group in the beginning will remain O negative because we've done a lot of transfusion, so it's almost like an exchange. And the baby may become anemic after some time. So after 1 month, you should always get a hemoglobin done for the baby. And there are very few long-term sequelae we've not found, but there is a big study of Lotus study looking at long-term neurodevelopmental outcome. But they have also spoken that the hydrops, when it is, and you do transfusion, the results are poorer. So I go on the last 5 minutes on some challenging cases that we had. I told you we have a triplet today that I'm going to transfuse tomorrow. And here we also had 3 cases of twin transfusions. So here there were 2 babies. So the problem is which baby to transfuse. Do we transfuse both of them together? Or if it is an MCDA, then does one baby's transfusion go to the other baby and take care of the other baby? So there were a lot of issues. So this was a baby which was a DCDA baby. The titers were high, and 1 placenta anterior, 1 placenta posterior. So the problem was approachability of this cord. So one we did into the placental cord insertion site. and the second one we did in the hepatic portal vein. The velocities were different. So it's not that the same antibodies, the anemia can be different in two babies in the same mother. So one intrahepatic and one in the insertion. And post-operatively also the monitoring, one caused hemolysis more faster than the other one. So one was worsening more than the other one. We still don't have answer why that happens. And so finally, these babies, when they had an MCA velocity which is high, we decided at 34 weeks to deliver them. So one baby had a hemoglobin of 6 gram only, while the other baby had a hemoglobin of 10 gram %. This one required 2 IVIGs and Paxil, while this other one only required a single IVIG. So in twins, we don't know what exactly happens and how antibodies work in this baby. This was again a twin pregnancy where there were antibodies, multiple antibodies in the mother. So there was no blood getting cross-matched with the mother. So you have to have a O negative blood, which has to be cross-matched with the mother. But here the mother blood was not getting cross-matched with anything. So we did a cord blood sampling, cross-matched it with the cord blood, and then transfused the baby at a second sitting. So these are very rare things that can happen. And third is, yes, if it is very early, as much as if you have a baby which gets hydropic at 16, 18 weeks, you may have to give them IVIG to these pregnant women at around 11, 12 weeks of gestation, so as to delay our transfusion. So that also we would have to do sometimes, and it is a very good method. So finally, this patient had 13 pregnancies, one live child, multiple abnormalities. So intrauterine transfusion is not an answer to every Rh negative. So you have to have combination of things which need to be looked at. So this patient who had 13, one pregnant live, all others abortions plus some hydrops, titers were positive, antithrombin 3 deficiency was there. She was started on heparin. NT was normal, uterine arteries were okay. The cervix shortened, so we required to do a circ large and then start on transfusion. So every time heparin had to be stopped, aspirin had to be stopped, then transfusion. The first transfusion at around 20 weeks of gestation, we had to do 4 transfusions, and by that time, 31 weeks, she and ICU could salvage this baby, and this baby is now 3 years old. So it's not only transfusion, you have to look at the patient as a whole and manage it as a whole. The last case of an NCDA, single fetal demise. So she had come to us in stage 4 TTTS. Institute, and we were thinking to do a fetoscopy, but next day morning there was an intrauterine fetal demise. So I know that yesterday night the baby was alive, and today morning the baby is dead. So this could cause acute transfusion to the surviving twin, and so there could be a chance of a fetal anemia in this baby. So in MCA PSV immediately we did, and we found that the MCA PSV was more than 1.5 mmol. So there are some studies where if you come to know about IUFD of one of the baby in a MCDA fetuses, you might try to salvage this baby and reduce the neurological damage. So here this case was a TTTS, one baby polyhydramnios, the other oligo had died, and so a long needle was used. Placenta was posterior, the cord was very far away, but we could do a transfusion because we could know that it happened in that 24 hours and the MCA velocity was high. So it could help, and we were ready to salvage this baby and take it further. So the transfusion was done. This baby is now 3 years old. MRI was done, which was also normal. She went on till 36 weeks and delivered at 36 weeks with an MCDA with the transfusion. So there are a lot of such cases that we have. So I thought because RH is such a common topic, I bring about newer cases so that you all see and understand how to manage them. The last point that I want to say is that MCA velocity should be used significantly so that we don't have babies with hydrops coming back to us and they are picked up early and referred for transfusions. Thank you for a patient listening, and sorry if I was not able to hear in between.
Thank you, Dr. Vandana. There was a little disturbance in the audio. It was very clear, the message. And as you were talking, I was thinking your patients are always fetus. So fetus as a patient. So I think it was very sad to see that one of the slides where the fetus was there lying like that. And last decade, this RH isoimmunization treatment has changed a lot. And I think we are doing more of non-invasive testing and then assessing the fetal anemia, and even the treatment has changed a lot. The outcome has become better also. Thank you a lot, Vandana. It was very good.
Chinmayi, can we take a couple of questions?
Yes, ma'am. There are some audience questions, please.
Yeah. One, Pavani from Telangana has asked, she had a case of gravida 5, para 1, live 1, abortion 1, death 2, previous LS years, RH negative, at 35 years was complaining of decreased and tightness since 1 day. And her anti-D was given. Now she is 35 weeks, indirect Coombs test is positive. Her question is, if ICT is positive at 35 weeks, should I terminate the pregnancy? Over to Dr. Muralidhar.
Yeah, see, her ICT may be positive because she has received anti-D, right? So that's exactly why we always tell, when you have given anti-D, don't repeat ICT for 6 weeks, sometimes even to 8 weeks. It will be still positive, and you will end up with such a dilemma. So when you know very well that you have given antenatal anti-D, better not to repeat, unless there is another sensitizing event, another bleeding happens or things like that. In which case you have to repeat the anti-D. So unless there is fetal indication, which is other than it just being ICT being positive, I don't think there is any need to deliver early. Even now with isoimmunization, people are not favoring early deliveries and giving a life in the NICU. They are trying to take as much as possible to term. And this particular case, just because it is positive, there is no need.
And we can do MCA Dopplers at that point.
Exactly. Exactly.
There is one more question from West Bengal. Is routine anti-D prophylaxis at 28 weeks is really necessary if 4 weeks ICT in primary is negative?
It is really necessary.
So everybody note along with the Dr. Haldar. Okay. There is one more question which I take then over to Dr. Vindhya. There is a great question one has asked from Orisha. Is kindly elaborate on prenatal counseling of RH negative mother. I think Vandana should take it up because he includes management.
Yeah.
Right? Elaborate. Probably we may not have
Vandana, you can switch on your video now.
In a small nutshell.
So someone has asked about how do you counsel these patients, RH negative mothers who come to a fetal medicine expert?
Yes, because they are from Orissa, we have to answer.
Chinmay, I think I'm not able to open my video because the host has muted me.
Probably go on with your audio.
I can just speak it out. So see, if it is an RH negative mother which is not isoimmunized, then sir has already spoken. You give anti-D at 28 weeks and then post-delivery, you can give it again. But if it is an RH isoimmunized pregnancy, you need to sit with them and discuss with them what are the options available. So one is you need to tell them they need to come back for these MCA velocities frequently. How much requirement for transfusion you have to talk to them. So if it is the first pregnancy which is positive, you could say, okay, we will monitor, but this monitoring requires a good fetal medicine or a good radiologist to monitor. And we probably may go on till term, but you need an institutional delivery. But if you've had a previous baby which is affected or your titers are now positive, I am going to follow you with MCA and the result of transfusion will depend on where you are working. So for me, I give them a result of 90%. So I tell them the intrauterine transfusion, if you don't do in this 1.5 MOM, the baby is definitely going to have a problem. And if I'm going to do a transfusion, 90 to 95%, I'm going to give you a good baby. And I will require your transfusion more frequently after that and monitoring more frequently. So the results are according to where you are working. So my results I know is 90-95%, but also she will require to be delivered in an institution where the NICU is very good. We should not forget the NICU, because this exchange transfusion, the monitoring which they do is also required. We may be best in our work, but we need to have the NICU backup with us also. So I would still keep them very positive, because this is the most treatable disorder in fetal medicine. So Rh negative is something which you have to tell them that the results are very good, and you need to be at right place at the right time.
Over to India for the next question from Uma Chauhan.
Can't see any question, madam. Can you?
It's a very interesting question. They've asked whether anti-D is necessary if both father and mother are rhesus negative. I definitely
from
want
New
this to be
Delhi.
answered.
Question is from New Delhi. Vandana, please note it from your place.
Not required. If both are negative, we don't need.
Both
are I think we have to go and ask somebody.
Then there is a question from one Shilpa Agarwal from Mumbai. What is your preferred site for IUT?
Shilpa has worked with me. She knows, but then.
Why did she put the question? Probably she wants to see her boss answering.
So both things. It depends on the operator experience. So I do more of placental cord insertions. But if I don't get a site, then I do a hepatic portal vein. There are people who do portal vein as first option. I do first as placental cord insertion site. Both have got the advantages, disadvantages.
Then one last question is, in case blood is incompatible with mother's blood, please look for other antigens in the mother.
Yes, madam. So the case that we shown, we tested for the mother. There were multiple antibodies in that patient. So we actually thought what to do. We went through blood banks and everybody to ask what to do. So finally, we took out the baby's cord blood and cross-match with this and transfuse. Very rarely, but it is possible that can be there.
And one point is
Sita wants to answer the last question. Sita wants a question. After that, you can conclude, Chinmayi.
Yes,
Sita?
Chinmayi was saying something. Go ahead, Chinmayi.
I just want to make one point. In that last question where they asked that if the couple are both rhesus negative, should we give anti-D? Well, anti-D you might hold, but please don't restrain yourself from doing an ICT. Everybody should have an ICT, because she might have had a previous blood transfusion. She might have had something else. So if the ICT is negative and both couple are negative, it's a judgment decision that you're not giving anti-D, but please do the ICT.
Yeah, that's a very good point, Dr. Chinmayi. We should always ask the history, whether there's a possibility of her receiving a wrong blood transfusion. Sometimes she would have received without knowledge, and she may not have had a very serious problem because of that. Yes, good one.
If the patient is undergoing tubal ligation, do we give anti-D? Dr. Pai.
Well, see, unless you have a reason to believe that you would have transfused her Rh positive cells somehow while doing tubectomy, then yes, otherwise no.
No, next time.
She's not going to have a plan.
Only then, in this era of ART, even after a tubectomy, I will rather, as an ART person, I will be worried. I will definitely say yes to the immunization.
You never know. You never know when they can change their mind, isn't it? So it's better to be. Yeah,
Dr.
one
Sita,
question.
You wanted to ask something?
Yeah, one quick question to Dr. Vandana. Actually, two. Do you always paralyze even if you do an anterior placenta with cord insertion?
Yes, I do most of the time, because the baby can just put his
Move,
foot on the needle and the needle may jump out. So I usually do a pancreas.
You always paralyze. And second question is that how quickly do you do a post-transfusion hematocrit? I mean, how do you sort of, you wait for some time, or because there could be some dilutional factor with the, or it could mixture with the transfused blood?
You're correct in asking that. So first I will do the first sample, then do the transfusion, then I put the needle back so that it gets into the circulation. So few seconds, and then I take out the needle and take the post-transfusion hematograph.
So that is more or less reliable, isn't it? That's what
because the circulation is going in, no? So after the needle is brought back out, it's from the mother, from the fetus directly. So I would put that needle in, which will tell me it has gone into the circulation, then take a sample. So
sometimes some people just use a small syringe to aspirate some and put back, so that you are kind of going back and forth for some time before you aspirate for hematograph.
Some people have suggested to put a bit of saline as well to just flush out the...
Flush out and then do the count. Right. Okay.
There's one interesting question from Rajamundri. Does RH incompatibility cause fetal anomaly also along with anemia? Surya Kumari Alamarti. Dr. Vandana.
It doesn't cause any anomaly except eye drops.
Head drops is not an anomaly. It's a complication that occurs.
Yes.
Baby may have an independent anomaly. That's different.
Thank you. Because it's a very valid question, I thought, whatever she is asking. Yeah. So, to Sangeeta, you raised your hand.
Yeah, Doctor, thank you, ma'am. I just wanted to make the point that I had put in that comment. It was not a query. And because I faced a problem, we got 5 units of blood cross-matched with the mother's blood before an IUT, and every time it would come as a failed or incompatible result. And finally, we got the antibodies done in the mother, and the mother had anti-C antigen positive, and then we had to fetch that particular blood, which was not having antibodies to anti-C, and only then we could make a successful transfusion in the IUT in this patient. And we should be very careful in not transfusing these babies with blood which is not matching with the mother, because it can be fatal for the mother. Thank you so much.
Thank you. Excellent deliberations, excellent question answerings. And myself, on behalf of India, thank you profusely for this opportunity, and bless you, Chinmayi, to grow more.
Thank you, more. Thank you, ma'am. Thank you so much.
Thank you. All the best, Chinmayi.
Thank you, ma'am. Thank you, Jai, ma'am.
All
Thank
the
you,
programs in FOGSI.
Murlidhar sir and Vandana ma'am, very nice, and it was really a very, very nice discussion. It can go on forever, but we have to now move on to the next session. So before we go on to the next session, ma'am, I think Dr. Nisha will just share the answers of the quiz.
So ma'am, after such a lucid talk and after such good take-home messages, I'm sure now if we run the test, we will be getting 100% in all the answers. But for the completion's sake, I give the answers to the audience. So our first question was, which of the following is not a potentially sensitizing event for development of Rhesus cell isoimmunization in pregnancy? And the answer was paleness vaginal spotting less than 12 weeks, as sir said.
Shall I ask you, why did you ask this question?
I knew you were going to answer it, sir.
No, not that. It's a very pertinent question. I'm happy that you put it, because
you actually persisted on the cramps. And
yes, this is a very important question. Many people have this doubt. So I really congratulate you for asking this question.
Yeah. So let's see, sir, how we performed. So 45% of them got the answer right. And I'm sure after your talk, it will go on to 100%. I'm sure all of us will answer it 100% next time. Coming on to the next question, when should an unsensitized Rh negative woman be screened in pregnancy with ICT?
This should be 100% answer.
Yes, so the answer is booking, and 2/3 of the audience answered it correct. At booking, we need to test. Coming to the next question, what is true regarding anti-D prophylaxis? And the answer is it can be given up to 4 weeks of the sensitizing event, and it was very well highlighted by Sir's talk. And let's see how many of us did it right.
I think the audience got confused, because optimal time is definitely the 72-hour period.
Yeah.
But if you look at the question carefully,
it can be given.
Only. Yes.
Yeah. That's what I told. It can be given, but best is of course 72 hours.
Yes.
So here I'm sure the tables would have turned after the talk.
Yeah. So after the talk, all of them would be giving the correct answer. That is the option number C. Coming to the fourth question, and very well elaborated by Madam and Sir also during their talks, which vessel, fetal vessel, should be examined for monitoring isoimmunized pregnancy? The answer is middle cerebral artery peak systolic velocity. And let us see how many of us have done it right. Almost 61% have done it right. And now I'm sure that it will go on to 100%.
100%.
Yeah. So next question is, which blood group should be used for intrauterine blood transfusion? As Madam rightly said, O negative blood group. Leukodepleted O negative blood group is the answer. And let us see how many of us did it right. 76.9%. It's close to 80% have given the right answer.
This shows the audience are also well sensitized for the RH negative.
Yes, yes, madam. True. Audience are well sensitized to RH isoimmunization. So
fantastic, Chinmay. This is the way to conduct the webinar.
Thank you,
Pre-test
sir.
and post-test.
Thank you.
Thank you, sir.
Making even the faculty sit to the end of the session.
Yes. Give the answers at the end. But you need to have a post-test, no?
Post-test we'll do, ma'am.
They will make the arrangement.
Jaya madam has made Science Integra promise the same.
Yeah, next time.
Okay, Nisha, quiz for the next.
Yeah, so after such an informative session on RH isoimmunization, we next move on to the engaging panel discussion on recurrent pregnancy loss. So as the name suggests, recurrent pregnancy loss is a recurrent problem, poses a recurrent dilemma to the clinician. So let's have a short quiz for the audience before we start the panel discussion. So I'm starting the quiz now, right away. Madam, can you please share the screen?
Yeah,
and
Session has to show the poll. The poll is on and the audience has to answer.
And one message to the audience that the question is going to be displayed in the bottom corner of your screen. Please take the poll there. Do not give your answers in the chat box because it will be valid only if you give it in the poll. If you choose your answers in the poll.
Alicia?
So coming to the first question on recurrent pregnancy loss, which of the following investigation is not relevant in the case of recurrent pregnancy loss? Well, options are chromosomal testing, TOG profile, anatomical assessment, endocrine profile. Please give your answer in the poll. Coming to the next question, Eshe defines recurrent pregnancy loss as. Well, the first option is 3 or more consecutive pregnancy losses more than 24 weeks, 2 or more consecutive losses less than 24 weeks of gestation, 3 or more consecutive pregnancy losses less than 24 weeks of gestation, or 2 or more consecutive losses more than 24 weeks of gestation. So a lot of numbers, signs, greater signs, less signs. So please watch out and give your answer in the poll.
Next.
Coming to the next question, chromosomal abnormality usually expected in a couple with a history of recurrent pregnancy loss is. So the question is in the couple with recurrent pregnancy loss. So options are Down syndrome, genetic syndrome, balanced translocation, and the last option is unbalanced translocation. Next question. So with the history of recurrent pregnancy loss, the expected chromosomal abnormality in products of conception is A, Down syndrome, genetic syndrome, balanced translocation, or unbalanced translocation. Next question. So coming to the last question, in a diagnosed case of APLAS with recurrent pregnancy loss, what is the most appropriate time to start low-dose aspirin and low molecular weight heparin? Options are low molecular weight heparin should start before conception and aspirin after confirmation of pregnancy. Both aspirin and low molecular weight heparin should start after conception. Aspirin before conception and low molecular weight heparin after confirmation of pregnancy. And both aspirin and low molecular weight heparin should start before conception.
Okay.
So please give your answers in the poll. As you all take the quiz and give your answers, I move on to the panel discussion. It's my pleasure to introduce the enthusiastic moderators for today's session, Dr. Krishna Kumari ma'am and Dr. Chinmay Datta ma'am. Both are excellent academicians and vivid orators. Dr. Krishna Kumari ma'am, I welcome you. You're my teacher, mentor. She was a gold medalist during her post-graduation. Currently a professor at Apollo Institute of Medical Sciences and Research. She's also a senior consultant in Medicover Women's and Child Hospital. She's currently the national corresponding editor of Jogi and national coordinator of FOGSI. She has held various respectable positions in the past, such as President OGSH, Vice President PCOG, Governing Council member of ICOG. I welcome you, Madam, as one of the moderators for today's panel discussion.
Thank you very much.
And then coming to Dr. Chinmay ma'am, I'm sure ma'am doesn't need any introduction. She's currently director and lead consultant in fetal medicine in Resolution Fetal Medicine Center, Hyderabad. She has many publications and papers on fetal medicine to her credit. And I welcome Madam as one of the moderators. Presently, she is the
It's okay. Disha will move on.
chairperson of FOGSI Perinatology Committee. I welcome Madam, and the floor is yours. Let's start with the panel discussion.
Thank you so much, Nisha, and it's wonderful having you with us. Very fresh and new ideas. So I welcome our esteemed panelists today on behalf of myself and Dr. Krishna Kumari for this panel on recurrent pregnancy loss, which, like she said, is a very recurrent problem and something which we are always confused about. Sangeeta Madam is a professor in the Maulana Azad Medical College, New Delhi, and somebody who went abroad and learned fetal medicine in one of those early days when fetal medicine was new in this country, and someone who brought in fetal medicine into the government sector so that she started the first trimester screening, all the fetal medicine protocols in Maulana Azad Medical College. I've had the opportunity of interacting very closely with her when I was in Delhi, and she's somebody I really look forward to hearing on all fetal medicine forums. Welcome, Madam, to this panel. Dr. Sita Ram Murtipal, again, someone you know very closely from Kolkata, the other end of India, that side, and very, very passionate academician, somebody who goes into the depths of all the studies and is extremely well-read and updated about all the concepts. And she is actively working in fetal medicine and genetics in this country and is looking for bigger roles in FOGSI to do the same. We wish you all the best, Dr. Sita, and currently a consultant in Apollo Gleneagles in Kolkata. So welcome to the panel. Dr. Veena Panath works in Aurangabad, and I'm very proud to say that she went all the way to FMF accreditations by working on her own patients, collecting her own pictures, and making sure that she got them certified at an international forum. One of the first people in Aurangabad to get certified for fetal NT and anomaly scans. And she really sets the benchmark very high. Someone who has worked in different, we wanted people who worked in different sectors, right from the top corporates to the second tier cities, where we can share the experience of how exactly they are dealing with this problem of recurrent pregnancy loss. Dr. Veena has been the secretary of the Aurangabad Society and extremely active in all the academic forums. We look forward to your inputs in this panel. Dr. Vidhu is from Ludhiana. Again, another a person brimming with excitement about new things, and she works. She is part of our perinatology committee and a life member of FOGSI, SARS, SAFOG, and IFS. Although she has an inclination towards fertility, I'm sure she will have a lot to give us in terms of her inputs on recurrent pregnancy loss. Welcome, Dr. Vidhu. And then Shyama Devdasan, one of my young friends from Thrissur. And she comes with a background of fetal medicine and genetics, and therefore she looks at another spectrum of this entire problem. And I welcome you also into this panel. So with that, I will stop sharing, and the floor is yours, Krishna ma'am, because you will set the ball rolling here.
Okay. Thank you very much, Chinmayi. And it was, I think I'm really, we have a very esteemed panel members from North, South, East, and West. It would be wonderful listening because I've never heard many of them till now. Most of them, I think I had only heard Sita speaking before. It would be a wonderful experience to me to have all these esteemed panelists.
And at the outset, I would like to wish you all the best in your future endeavors, and God bless you. And I think we had a wonderful, wonderful first hour. Now we move on to this panel. Of course, we'll try, you have balanced the unbalanced very well. Hopefully we'll go ahead with finding what the opinion. We have been hearing so much of RPL every day, time and again, that I want to hear only from my esteemed panelists what their opinions are regarding different issues. The pregnancy loss, we all know that only out of all the conceptions that do happen, only really 30% get converted into live births. Most of them are lost somewhere from the time of conception to the time of birth. So can we move on? So I think this is the first question commonly asked, and I would like to take an opinion from our panelists regarding what they consider as recurrent pregnancy loss. How many losses would they consider as a recurrent pregnancy loss? Can we start with Dr. Sangeeta? Dr. Sangeeta?
You're muted, madam.
Sorry. Yeah. So good evening, everybody. And I would thank Dr. Chinmaya for this opportunity first. And as far as the incidence of recurrent pregnancy loss is concerned, I think it varies by the criteria you use. So if you're going to use the criteria as 3 or more losses, it will be 1 to 3%. Whereas if we take the losses or 2 or more, it is almost to the order of about 5%.
So what do you take? Do you take 2 or do you take 3? And what makes you say 2 or 3?
Yeah. So, madam, previously we were taking it as 3, but now recently most of the people are resorting to 2 losses as labeling them, start investigating the patient for RPL once she has had 2 losses. And I think that this should be a shared decision making with the couple. And one should also take into account the available resources one has. And then there are certain scenarios which warrant an early investigation, particularly if the couple has been already being investigated for infertility, or if the female partner is already more than 35 years of age, say that's the advanced maternal age. And if there is a documented cardiac activity in the previous losses, then we know that probably it could be APLA, and treatment is definitely going to alter her outcome. We should start investigating these women at an earlier loss, or if previous products of conception have a normal karyotype. So these are one category where I would initiate the investigation before early rather than late.
So as far as the karyotyping of the previous products of conception are concerned, we'll keep it in abeyance. The discussion we will come to later.
Okay.
Yes. Now, as far as you rightly said, there are many risk factors which make us associated factors, in fact, which make us decide whether we should go ahead with 1 or 2, 2 or 3, even sometimes very rarely, even with the 1 pregnancy loss. Suppose a woman is closer to 40, even with 1 pregnancy loss, it becomes very imperative on our part to find out if there is some reason behind it. So coming to this case, this is a para 3 live 0 with IUD at 32 weeks because of severe preeclampsia. And then second pregnancy, again, she had a PPROM at 30 weeks and had a normal delivery, but had with extreme prematurity. And third pregnancy, she had a miscarriage. So with these, she doesn't have any live children. Dr. Sita, do you call it recurrent pregnancy loss?
Thank you, Dr. Krishna Kumari. And at the outset, I'd like to thank Chinmayi and congratulate her on her first webinar on program of her perinatology committee, and wishing you all the best for the future activities. Thank you. So this ideally recurrent pregnancy loss is defined as any pregnancy that ends in miscarriage before 24 weeks of gestation. So in this example that you have given, one is 32 and one is 31. So it does not exactly fit into the definition per se of pregnancy losses. So, and sometimes, even in our country, I would consider 20 weeks as well. So you wouldn't wait till 24 weeks, even less than 20 weeks, I would consider as a recurrent pregnancy loss. So any pregnancy that ends in miscarriage before 24 weeks,
But do you
according to
think there is something common between these history?
Yeah, obviously. So we'll have, of course, doesn't fit into that definition, but there is a cause for concern here because the mother doesn't have any living child. So we have to investigate in terms of an APLA or, those autoimmune factors which could causing a recurrent loss here, but it is not exactly a recurrent pregnancy loss.
Yeah, it doesn't fit into the definition, but the outcome is equally bad and
important to investigate.
Yeah, very important to investigate her. And like you rightly said, maybe first thing we would do is look at whether there is any APLA, if she is APLA positive, I think, with preeclampsia, early pregnancy loss, so many placental factors pointing at us. So can somebody, Dr. Veena, can you tell us about the risk factors? What are the various causes of recurrent pregnancy loss?
It is very difficult actually to enumerate one reason, but yes, definitely we have to look at her entire history. What is the age? What is the lifestyle? What is a BMI? Then we go in for a routine pelvic examination, a detailed transvaginal sonography, ideally a 3D scan also, so that we are able to just rule out all kind of uterine anomalies. Then we definitely go in for blood investigations, that is the thyroid and the other not all hormones, but yes, definitely the thyroid. And then definitely we offer the APLA testing for her. For this patient, because you said he has one loss and then the first pregnancy she has lost because of severe PIH. So all these work in favor of offering her APLA testing. And I think APLA and thyroid along with the lifestyle, these are going to give us a fair idea of what is the problem in this particular pregnancy so that we can offer her proper management for the next pregnancy.
Yeah. So I think there is almost ASHRAE, ASRM and RCOG, they almost agree on what are the associated factors that we have to look for, which could be there with this patient, as well as what are the investigations we should go ahead, because looking at all the etiological factors. So like you rightly said, you have covered most of the factors, anatomical, whether it's thrombophilias, embryonic, genetic factors, endocrine, immune, lifestyle, and most importantly, when you look at the risk factors, it is the maternal age as well as the previous pregnancy loss. So these are very, very important.
Can I just add in here, as you've rightly said, the two most important things to counsel this woman is the age and the previous pregnancy loss, because anything more than 2 losses, the recurrence risk jumps to almost 40 to 50%. So at the time of history taking itself, you have to reiterate what are the risks of subsequent losses, because we might not find anything, and that is an important factor to counsel. Thank you.
Very true. Very true. Can we move on? Yeah. So I think independent from the case scenario which we have seen, can I have Dr. Vidhu answering what is her opinion about investigations for anatomical factors which cause RPL?
Hi. Yeah, anatomical factors which we can usually it's not much role, but yes, we can do a 3D ultrasound, which is very important to see any kind of anatomical abnormalities in the uterus. 3D ultrasound is best, and we can also do sonosalpingo-hysterography, which is also very valuable in telling us any abnormality in the uterine cavity.
So you would like to do a 3D or a sonohysterography?
Sonohysterography.
Would you consider doing an MRI in a woman?
MRI has not been much recommended for this. So what, as of now, it's too much of cost factor in India, which gives us, which we should pertain to a patient, because as we are going to treat her for RPL, she's already burdened with the disease, with the problem. And so I think MRI can be avoided for now. If we can have
the first line, we need not think of MRI. It can be a second line investigation.
Yeah.
But suppose in most of the places, like suppose it's not in a corporate area or in a city or even in a smaller places, when you go there, you won't find a 3D or a sonohysterography.
Sonohysterography, I think so majorly people are doing more now.
Yeah.
I'm in a 2-tier city also, but there also many people are doing sonohysterography.
If you have a choice and you have the choice of ultrasound,
I personally do 3D myself.
Correct.
So
So
that's
if
more
it is available,
non-invasive.
the guideline says if it is not available or not accessible,
Yes.
then probably an MRI is a good alternative.
Good alternative.
Yeah. So can we have Dr. Shyama, what is your take on hysteroscopic septal resection, Dr. Shyama?
Dr. Shyama,
unmute yourself, ma.
Yes, madam. Good evening, all. At the outset, I would just briefly like to thank Chinmay, madam, and the entire panelists, and Shantakumari, madam, and all those who are present today for for including me in today's talk. That is the first Perinatology Committee FOGSI topic, and the question I would take is related to the uterine abnormalities, as madam rightly said about the hysteroscopic septum resection. In this, I wouldn't, according to the first line management of any uterine anomalies, the only thing that is conclusively evidence-based, I would say, is for maybe the polyp removal, endometrial polyp removals or hysteroscopic removal of submucosal fibroids. But septum resection as such, it is not recommended in all the patients, but of course, case-wise individual consideration has to be given. So hysteroscopic septum resection and other intrauterine adhesion removal, it is, you have to counsel the patients and go according to the individual case-wise management. Other than that, even the evidence-based, according to our guidelines, it is not recommended. That is my take on it, madam.
You're opening a controversy.
Yes, it is a controversy. Yes, madam. I know there is inconclusive evidence, so it is a based two-edged sword, you can say.
Can I take the opinion of the other panelists, Dr. Sangeeta? Back to Dr.
Yes, ma'am.
Working as a fertility
specialist. I think hysteroscopic septal resection has been recommended for patients of RPL if we pick up. Metroplasty or uterine reconstruction in a bicorporeal uterus and double cervix are not recommended. These kind of surgeries do not improve the outcome of these patients. So far, the evidence is in support of this concept only. And surgical removal of intrauterine adhesions, submucosal fibroids or endometrial polyps, also there is a debate. And I think here we need to individualize the patient where there is a larger impact on the cavity of the uterus. One must consider it.
So here the problem will come when the patient comes and tells you something and you say that, okay, we don't want to do the septal resection because it is not known to improve. And the patient will ask that question, oh, my sister had this, or my cousin had this, or my friend had it, and they did it, and after that she had a pregnancy. So yes, how would you counter that? I mean, somebody with experience in handling these patients, what would be your answer? Would you want to comply to the patient's wishes or stick to your evidence done?
No, as a fertility specialist, I think so. Septal resection does offer, but these are more for, you can say implantation failures. Like these people will usually come to us if we have a septum that they're not conceiving.
In the audience, I'm sure audience is also putting up questions. Please put so that we can answer, but they will ask that, should we do it or should we not do it? Is there a yes or no answer?
I think we should do it.
We should.
I think we should be proactive in offering treatment.
But we are talking about recurrent pregnancy losses.
Yes, agree. But
it is not like before the patient has, it is not she's a nulliparous or something where we are there, where we can always think later. We can always give a chance. But already the patient had 3 pregnancy losses, 2 or 3 pregnancy losses.
We have to be
would it affect your judgment?
See, it's a very debatable question and answer.
As Madam directly said, I think yes, as Madam said, after counseling the patient, definitely if that is what they want for, if they want to do it, if when we offer such a treatment, they want to do it, definitely we should go ahead with it. Only
what all of us need to understand is, as evidence starts now, see, we get driven by this evidence-based medicine, and as evidence starts now, we don't have strong evidence to recommend those treatments. The only thing that the guidelines have given us is if there is a cervical weakness, you go for a cervical cerclage, and that probably helps. But other than that, the anatomical factors have been described, but there is no evidence. Now, to generate that evidence, what kind of studies would be required, what kind of tests will be required, it will be a very, very long drawn process. So I think practically it makes sense to sit down across the table with your patient, individualize the treatment and explain it. But very informed consent and very informed decision. Krishna ma'am, would you agree?
Yeah, very true. I think you have put it very well. Counseling is very important, and personalized treatment is also very important. And the third important thing that I would consider is if you also have to look for other factors. Just because you have seen a symptom, don't get don't get the impression that this is the cause of this pregnancy loss.
Absolutely.
So evaluate for all the causes, and then if you don't find anything, maybe then you can sit down and counsel the patient accordingly.
Can I just add something? Yeah. Of all the abnormalities, the only little evidence is about the septate uterus. So that is another thing that we'll have to counsel them, and provided if it's done properly in the best skill of hands, if it's otherwise, there's no point doing an half-hearted procedure. So if you have the proper setup and everything skill to get it done, then you can offer this, saying that might not be the only cause, as you rightly said, madam.
Yeah, because like in fetal medicine, you see one anomaly, you look for all other anomalies. So similarly here, you see one cause, you look for all other causes because it may.
And not assume that's the only cause.
That's the only cause. So that brings us to the next point, which madam so nicely brought it into the discussion. So Krishna ma'am.
So endocrinological evaluation, what is your take on, I think we'll start with Dr. Sita on thyroid. How will you evaluate for thyroid?
So basically thyroid is...
Thyroid, first of all.
Yes, in all pregnant women, so we do look for TSH, and there is a debate about looking for TPO antibodies, and some studies said that TSH is more than 2.53, you look for TPO antibodies. But there is definitely evidence that correcting them and with following them up with, if it's abnormal, to give them thyroxine, that will have some improvement in their outcome. But definitely
in pregnancy, we may use that 2.5 cutoff, but in RPL, would you do a TPO antibody for everybody?
No,
I think we should. What about others? What do you think?
I think so. We can do anti-TPO antibodies, especially when it is a very borderline kind of a case. You cannot say that it is falling into a frank hypothyroid or not.
Good. We have 2:1. Now, Veena madam, Sangeeta madam.
As far as thyroid is concerned, we usually evaluate these women for thyroid function tests, and depending on the TSH level, we will do the TPO antibodies. Because if I can go ahead, if it is a euthyroid woman and there are TPO antibodies positive, then still there is no indication to start levothyroxine for them so far. These are the recommendations. If a woman has subclinical hypothyroidism with TPO antibodies positive, say her then one should think of one can consider starting levothyroxine. And of course, if frank hypothyroidism is there is no question, we are giving, and we are going to step up the dose as soon as she gets pregnant.
So would your approach be different for pregnant women and RPL patients?
No, it's going to be the same actually.
Actually, we have three scenarios here. One is frank hypothyroidism, where definitely there is no other discussion. We are treating them. There's another scenario where there is subclinical hypothyroidism, but TPO antibodies. The first to answer the first question, yes, we do TPO antibodies for all, let's say for all recurrent pregnancy loss cases. Then in case of subclinical hypothyroidism with positive TPO, then there is definitely, as as has been said before, we definitely there is a need for giving the patient thyroxine. There have been studies also where, in spite of the patient being euthyroid with positive TPO antibodies, they have given thyroxine supplementation, and they found it to be, of course, it is not strong evidence. Individual studies are there. It is not a analysis, meta-analysis or reviews or whatever. It is in the maybe a little lower in the ladder as far as the what you call grading of the evidence is concerned. but still have been studies where even in euthyroid with positive TPO antibodies, maybe desperate. Sometimes, the situations are so desperate in these recurrent pregnancy losses. So we don't know what will work. So, but there have been such studies.
And ESHRE, as of now, recommends TPO antibodies in all the things. Yes, Shama, Dr. Shama?
Yes, madam. Krishna madam just mentioned the last scenario. So if it is euthyroid patient and a TPO antibody positive, we start on, if at all, we start on a levothyroxine. Then how do we go forward? Like once the patient becomes pregnant, is it stepped up? Do we continue, or how
is it? That they follow up with the TSH.
Okay. Yes.
They just follow it up with the TSH. This has been a study. That's what I've seen, and so that it basically brings to the point that definitely it is indicating that there is something. I think TPO positive antibodies itself indicate that there is something going wrong immunologically. Yes, so it may reflect even in as far as the fetus is concerned also.
Endocrinology, yes.
Yeah. So now coming to other hormones, anybody does any other like prolactin or looking for in PCOS, fasting insulin?
So we don't look for
PCOS, no.
Lifestyle and
prolactin.
Prolactin, yes.
Yeah, the ASRM recommends prolactin. I think that's
mainly when there are clinical symptoms, madam. We do.
Even without clinical routine, ASRM for recurrent pregnancy loss recommends prolactin also. RCOG is not bothered even about TSH also.
TSH.
Yeah, so ESHRE is concentrating on thyroid. So these actually the panelists have to bring in which is the best of which to choose. So I would say, I think after to all of you, it is. Yeah.
Can I say something here?
Sure.
Yeah, I think as far as vitamin D supplementation is concerned, that even contributes to general health of a person.
Correct.
So I think how much confounding is there is not being brought forth, and it will be very difficult to comment whether it is actually giving benefit to RPL or not.
Yeah, but at least it is helping the woman. So
yeah, so that is a different question altogether. So we don't have any conclusive proof for that.
True, and their comment regarding vitamin D supplementation is also absolutely like what you said. It is helpful to the woman. Whether it is helping the RPL process or not is not known. So just like we give multivitamins, you can also give a vitamin D supplementation.
Yeah.
Or folic acid for that matter. They've written clearly folic acid does not prevent RPL, but then folic acid has to be given as a preconceptional vitamin.
As far as your PCOS part is concerned, they are writing that doing a blood sugar or a fasting insulin, anyway, preconceptionally, if a woman comes to you, I'm not talking of any RPL, any woman who comes, we would get a glycosylated hemoglobin or get a diabetes checkup, particularly in the Southeast Asian population, which has got a predilection for diabetes. And in a woman of RPL, I would always get a glycosylated hemoglobin, and that would be my deciding point.
But like you said, you would get a glycosylated hemoglobin in anybody who comes preconceptionally to you, because that's like a screening test for most women. So
it's not only glycosylated hemoglobin, any test for recently I had this one patient who had a pregnancy loss in the early weeks, and then she came to me with the second pregnancy, and she told me her husband is a diabetic, and the scan showed that there was a fetal heart with around 6+ weeks of gestation. I wrote for her the investigation, said come back, and when she came back, she had a very high blood sugar values. And she started crying. I said, why are you crying? She said, I thought only my husband had. Why do I also have to have blood sugars? See, that means it was missed after the first pregnancy. And now it is because the fetus was alive, we have first gone for the routine screen and we picked it up.
No, the point here is that we are doing the HbA1c and glucose to improve the general obstetric outcome and not as a particular reason to improve the recurrent pregnancy loss outcome.
Right.
Because that is not an attributable cause of the recurrent pregnancy loss. In general, that we do as a screening for all other factors, the HbA1c.
Absolutely.
I think what the point you're trying to make.
Many of the things in this list are actually.
So hardly 3 or 4 tests like APLA and all, which are really, really meant for RPL.
We'll come to that, ma'am. I think here the point in endocrine and metabolic disorders, thyroid testing is important. Testing by TSH has been recommended by everybody. TPO antibodies are the two governing bodies have given different recommendations. So again, see, that is where evidence will.
Panel has given go ahead, so we'll go ahead.
Okay, so if you can, then please do the TPO antibodies. That helps. Okay, now. This is a lady with 28 years old, 3 years married life. Both are software engineers, very healthy generally and planning for a pregnancy. But she has had 2 pregnancy losses at 6 to 8 weeks, no specific cause found. And now she's worried with her own risk of having further pregnancy losses. So are there any health behavior modifications that are relevant in reducing the pregnancy loss in a history of RPL? Veena, madam, would you want to take this? Do you want to change her health behavior?
Yes, before I ask her to change her health behavior, I need to know her lifestyle, what is the kind of lifestyle she is having, whether she is into exercise, a proper diet, whether in India things are changing, scenarios are changing, people are smoking, and I mean ladies are smoking, ladies are going in for alcohol consumption also. So I need to know whether she's into all of that, and then I can ask her to modify that behavior. And if her BMI is high, definitely exercise to reduce her BMI along with folic acid supplement. I think that should be enough presently to change her lifestyle.
And you'll ask about other, because the profile that I gave you was software engineers. So many of them have altered wake and sleep cycles, altered substance intake, and those kind of things. So do you think that makes a difference?
I think it makes a difference because most of the people I see, sometimes even the younger generation, the people sleep at 2 a.m. at night, they get up at 10 a.m. in the morning, and the lifestyle is changed, and they're definitely stressed, and the hormonal and metabolic milieu in which they conceive will not be very positive for pregnancy. So they have to change this lifestyle. They have to go back to a routine, early morning, early to bed routine, and that will also help in conceiving. And that is the way she should conceive.
So Vidhu, madam, if this patient comes to you and has a bad lifestyle and she's already had 2 pregnancy losses, are you going to first test for those pregnancy losses or recommend a lifestyle change first, or do both at the same time?
I need to counsel this patient first, tell her about how lifestyle can help her to achieve a better health and a better result. And yes, I need to tell her all the investigations which we would like to propose to get because she's had 2 losses. So both will go hand in hand to give a better result.
So just like we saw in the septum, we saw the losses, but we didn't stop at the septum. We did all other tests. So here also we are seeing the losses, we are seeing the lifestyle, but we are not stopping at lifestyle. We are doing all other tests. So somehow I think we are going to come to that circle where probably all the tests will have to be done rather than doing one first and one later on.
In this era, people are already read on the net and they come and ask us. So ma'am, this is done. This is even if after first abortion, they ask us, ma'am, can we do this? Can we do this?
But after first abortion, would you advise them to do, or would you tell them to?
Not all of them, would definitely give them a chance. First lifestyle. In this lifestyle, yes, and a lot of vitamins before they try one for a conception.
Sure. So now this is a patient with 2 miscarriages who has not had any genetic testing so far. Now, Dr. Sharma, what is the value of screening for genetic factors in the diagnosis of recurrent pregnancy loss?
Genetic screening, as far as genetic factors are concerned, yes, I would like to take on the question stating that there are on what do we screen, or where do we put the genetic tests? One is on the products of conception, and the next is for the parents or the paternal and the maternal part. So ideally, as we all were looking at the governing bodies, around 2 of them, other than the ESHRE, the other 2, they do mention that products of conception can be subjected to a genetic analysis. Mainly, rather than going in for a karyotype, we try to do more of, reduce the maternal cell contamination and hence going for an array CGH. As far as the parental karyotype is concerned, it is not routinely recommended, but definitely individualize the patients. You have to take a detailed history, as we have always been mentioning, detailed history, if at all the products of conception, they come out with some form of an unbalanced structural chromosomal abnormality, then we could go in for a parental karyotyping. It is not mandatory. As a FM consultant, I wouldn't consider it mandatory to send for a karyotype in all patients, but definitely after counseling, looking at the individual risk assessment.
Dr. Sita, she told us two tests. One is an RACGH and one is a karyotype. Would you just like to tell us the difference between the two?
So I completely, at the outset, I completely agree with her that you don't need to generalize and do a karyotype, parental karyotype at the outset, because we need to look at more other causes, because the karyotype looks at the gross abnormalities, the big abnormalities of the, big major deletions or major changes in the chromosomal pattern. So you will miss out on the small ones where the microarray goes into a deeper resolution of these chromosomes and picks up small deletions and duplications or inversions, which can be a cause of the recurrent pregnancy loss. So if you have to do an ideal one-point test and cost-effective test, it would be the chromosomal microarray. And if anything is abnormal is found in that, then we can go ahead and counsel the couple to go on to find out a parental karyotyping, because if they have any unbalanced translocations, which can cause a balanced translocation in the fetus and cause recurrent pregnancy loss, and then accordingly send them for genetic testing. So karyotype is basically looking at overall picture of the 21 chromosomes, picking up gross abnormalities like a triploidy or tetraploidy or a trisomy, but a microarray picks up smaller problems in the chromosome, which are like duplications and deletions, which can be a cause of the recurrent losses.
So basically, the parents may be balanced translocation carriers. That is why they are normal adults. That was one of your MCQs to start with, because the parents could be balanced translocation carriers, which is when they will not display any problem themselves, because they have exact component of genes as is expected. But when they form gametes, they may form unbalanced gametes, and therefore the product of conception can have unbalanced translocations. And the difference between a karyotype and a microarray, as Dr. Sita rightly said, a microarray is a very high resolution karyotype. So you actually see much more. So if there's a major deletion or duplication, you may see in the karyotype. But if it's a small micro deletion, micro duplication, you will see it only when you do a high resolution examination like the microarray. The other advantage is in recurrent pregnancy loss, the present pregnancy is already lost. So there are no viable cells there. So you cannot grow them into a karyotype. All you can do is some kind of fish or something that we were doing earlier. Now with this array technology, that DNA can be used and elaborated to check for those minor deletions and duplications. Because when we were doing fish, we were only able to rule out major aneuploidies at that stage. So
yes, the result is what is important.
Maternal cell contamination.
Right.
Reduction.
So, Sangeeta ma'am, what would you suggest? Like, if a woman is undergoing recurrent pregnancy loss, when and where are you going to suggest the genetic testing?
So, Dr. Chinmay, there are a few, like we have all discussed, if there is a third loss, that is the time before she's undergoing a termination, we should counsel her about this option of products of conception microarray. Microarray is important here. Karyotype will fail in 70% of the patients, and we are fortunate that this technology has helped us overcome this limitation. So one is this, that it has to be a microarray. When she has a third loss, that's the time to counsel her that yes, now you need a another modality of investigation. This is the time we will ask the woman that she should get a genetic testing done for the products of conception. And if this product of conception shows a translocation defect, the unbalanced translocation, of course, in microarray, balanced translocations will not show, then there is a reason for us to investigate the parents further. However, if it is a trisomy or a triploidy, then the risk of recurrence is, for trisomy, it is almost going to be to the order of about 1%. Parents need not be investigated any further, and the woman can be counseled that she can opt for a screening method or a diagnostic method in the next pregnancy. And if it is a unbalanced translocation, this is one condition where you would like the parents to be investigated further with the karyotype 1. Another important thing which we must remember, where we would ask for a genetic testing in the fetuses, if there is any anomaly present in the fetus which was diagnosed before there was a demise and there was an anomaly, or there was an increased NT on a scan, or then we can, depending on the anomaly which we have diagnosed, we can offer them genetic testing.
Perfect. So when we see recurrent fetal anomalies, we will think about genetic testing, and at least after 2 miscarriages, if we want, we can start with the product of conception and then go on for parental karyotyping, because like most of the bodies have not recommended parental karyotyping as the first line of test, but subsequently with a good reason, we can go for that.
I want to add just one point, Chinmayi. It's not only the identifying the particular problem for this particular fetus, but it also gives the patient or the consultant a reassurance regarding what went wrong in the pregnancy.
Absolutely, very
important, madam.
If the baby is a euploid, let's say everything is normal, then definitely it is an indicator that you have to investigate more thoroughly for other causes.
Other causes, absolutely, ma'am. And that's very rightly said, because only if that product of conception has problems, then only we need to go back and check for parental karyotyping, ideally. But because of cost consideration, sometimes people think that, okay, again, we'll spend on this one, and then if it is abnormal, we'll again spend on checking ourselves. So some people want to do parental karyotyping. So again, individualization. I mean, evidence is there for both the things, but we need to sit and have a good chat with the parents.
And Dr. Chinmayi,
yes,
if you go one step further, sometimes you are treating a woman of RPL, already treating her, and despite the treatment, she's not giving you a optimal outcome, then probably that is another indication where one should go ahead and check for genetic analysis of the products of conception.
Yeah. So in fact, you can divide these into, like, as madam said, as you know, if it is a euploid, you know, there are other causes. If it's aneuploid, it is basically because of age or the previous losses. And if it's unbalanced, then you look for balanced carriers in the parents. No, you can sort of do a
exactly, Dr. That's the algorithm goes that way.
Yeah.
So now we've checked and we found that the parents carry a chromosomal aberration. Vidhu ma'am, they've now come to you. They carry a chromosomal aberration. You are the fertility specialist. How are you going to help them? Dr. Vidhu, are you there? Avina ma'am, you can take this question.
Maybe she's muted herself.
I think with this era of implantation, diagnosis and screening, we can offer that to her along. We can just tell her that next time they plan pregnancy, then definitely they can go in for IVF, and then we can go in for pre-implantation genetic diagnosis and accordingly decide. And it should work for her benefit also.
Okay, Vidhu ma'am, are you there? Hello? I think we've lost our connection. But
Dr. Chinmayi, can you share what kind of an abnormality does the parent have? That's very important. And
let's take a balanced translocation between 9 and 2, chromosome 9 and chromosome 2. The mother is carrier of a balanced translocation between chromosome 9 and chromosome 2.
Yeah, so there are 2-3 things here. One, I think we are not geneticists. So I would definitely send the couple for a genetic consultation. That's very important, because that is the most competent person to decide how to take it further. Number 2, if the balanced translocation is in the mother, usually, then the chances of having a fetus with unbalanced is much more than if it is the father who's the carrier. Particularly when it is in Down syndrome, we say in these cases. Then number 3, the type of translocation. There are certain translocations where the carrier rate is going to be 100%. And for these patients, the only option of having a outcome is either to have an IVF with donor gamete or they adopt. And as far as IVF and prenatal genetic testing is concerned versus conception and prenatal diagnosis, they have usually seen that IVF and PGD is not improving the outcome, because even if you have a prenatal screening, you anyway have to go for a confirmation after the patient becomes pregnant. This is what the results have shown.
So
of
thank
course,
you, Sangeeta
the
ma'am.
final choice is by the parents. You will give them all the options.
So I think some points which we have to be very clear about these genetic aspects and RPL are, number one, that yes, genetic causes can cause recurrent pregnancy loss. And in fact, more than genetic, they are actually chromosomal causes, which include chromosomal translocations or chromosomal microdeletions, duplications. So first and foremost, if we have a choice, check the product of conception, because if the product of conception is chromosomally normal, then we are not thinking about that cause in the parents. At least for that pregnancy, we can be sure. If the product of conception is abnormal, then we have to check the parents, because whether it is a one odd abnormality or whether the parents are carrying it. Here, the little caveat is there might be gonadal mosaicism in the parents, where every time they might be having a problem in the gametes that they are producing, but that is not present in the peripheral blood smear that we are getting. So that's again another tricky bit there. But suppose we discovered that the parents are carrying a certain chromosomal abnormality, like Sangeeta ma'am said, it's always better. However clever we are, every field is growing in strides like anything. So even in RPL, if you realize there are certain people who are more comfortable with the genetic aspect of it, there are certain people who are more comfortable with the septum aspect of it, certain people who are more comfortable with the metabolic aspect of it, and certain people who are more comfortable with, just general treatment there. So here also, it will be useful to use a clinical geneticist, get the idea of what is the recurrence risk, and then offer them the solutions. So if the parents are carriers, proven carriers, replacing gametes is an option, which can be done in IVF by a donor gamete. If that is not an option, then pre-implantation genetic diagnosis is what they can think of. If nothing works, they can adopt a child. So that clarity and that complete list has to be given to them, because translocations are difficult. How many times she has to undergo a miscarriage to get the correct combination. Everybody doesn't have the same sturdy thought process. While some patients will say that we don't mind. Even if we have 15 miscarriages, we will wait till the right combination comes. So be it. So finally, it's the patient's choice, and we end up again counseling. So Krishna ma'am, over to you.
Okay. So now the same case, everything was normal. So would you look for any male factor which can contribute to recurrent pregnancy loss? Shyama?
Yes.
Dr. Shyama, are you there?
Yes, madam.
Yeah.
Here again, as we have already discussed, it's about the lifestyle manifestations. Like first and foremost, the history. From the history, as they've rightly said, they are both software engineers. So we had come across how to target the female partner, what all we'll be asking about the lifestyle factors. So similar thing will be extrapolated to the male factor. So the male partner, he should be assessed for all these, and excessive alcohol consumption, smoking cessation, all that is required. Then the next thing we come across, relatively new kid on the block, is about the sperm DNA fragmentation. And that it can be considered in cases of, we are dealing with recurrent pregnancy losses. So when you don't have an answer, when we have been investigating all around for other factors, along with that, definitely sperm DNA fragmentation can be considered, offered to the patient, told them about the pros and cons, advantages of doing such a test, and finding out if there is an abnormality. So here, I think the ESHRE, yes, madam. I think out of all those three, our three bodies, governing bodies, ESHRE is the one who recommends that, and the other two, RCOG is silent, and ARSM
has not recommended, but ARSM is the older guidline. The ESHRE has come
ESHRE
later.
is the latest, 2017.
And that also says only consideration. Doesn't
Dr. Chinmay, they have only said it. They have particularly, we should underline that can be considered.
Right.
So it's not recommending. It's just the level of evidence is low for supporting this kind of practice.
So our fertility specialist, Dr. Vidhu, do you have a different opinion on this?
I don't know, Doctor. We think we have lost Dr. Vidhu.
We are not getting her online. Okay, Dr. Veena, you want to say something different here?
Sperm DNA fragmentation, I think I would offer it to the patient, because many times we know that because 50% of all the chromosomes and everything comes from the father, it's better to offer this test. It's better to be proactive.
So all the fertility people will be proactive about it. The others will have a little thing, but I think that's it. I mean, again, individualized discussion and understanding. So what therapeutic intervention? So as everybody has said, lifestyle modification definitely has to be taken into account. And therefore, this is an important take-home message, because when we write our prescription, somehow we start with our medications. So here is a situation where lifestyle modification has to take precedence, because not only you are improving their health now, but making them better candidates for pregnancy whenever it comes. And sperm selection as a routine is not recommended, and antioxidants have not been proven. So evidence is poor on these two things, but again, evidence has its own limitations. So what is the value of thrombophilia screening? Krishna ma'am, you can take this.
Did you ask me, Chinmaya?
Yeah, Dr. Sangeeta, you can start.
Yeah.
What do you think?
So, thrombophilias can be broadly classified into hereditary thrombophilias and acquired. And one thing has been brought forth is that hereditary thrombophilia is not associated with RPL. They are quite exhaustive and expensive tests, and they are not required. What is very important is that these women should be investigated for antiphospholipid antibodies. And for that, we have lupus anticoagulant, anticardiolipin antibodies, and beta-2 glycoprotein. So these three set of antibodies have been implicated, and they should be done. And they should be positive at least 12 weeks apart to label the patient as APLA positive.
So we need to have at least one clinical and one lab evidence to say that they are APLA positive. I think we won't go to the Sapporo's criteria and all.
But madam, nowadays there is a lot of literature which is coming about other categories of APLA. I think this forum doesn't allow us the time to talk about them in detail. But this is what is important about APLA is that once it is picked up, the treatment of APLA is there, and it significantly improves the pregnancy outcome.
Yes. So what is the treatment you would like to advise for this?
These women need low molecular weight heparin and low dose aspirin, both. Now, as far as low dose aspirin is concerned, that should be started preconceptional for the woman. And low molecular weight heparin should be started once her pregnancy is confirmed, even if it is a urine beta HCG testing. We need not wait for an ultrasound to show a sac or a cardiac activity to come. So this is important. Another thing which I want to bring forth here is that in these women, they are predisposed to developing complications during the course of pregnancy, like prematurity and FGR and hypertension. So they need close monitoring during these pregnancies for development of these complications. And third, they again are predisposed to thromboembolism. So this low molecular weight heparin should be continued for 6 weeks postpartum.
Yeah.
And what is the dose in which you will start aspirin?
So now most of them are saying 75 to 100, but Chinmaya, I think it is a time to revise, because we are already saying these women are predisposed to hypertension, preeclampsia during pregnancy, and we all know that 150 milligram of aspirin is the dose which should be given for prevention of preeclampsia. So I think whatever the guidelines are saying, I would start her at a 150 milligram if.
But if somebody wants to follow the guideline also, madam, I think it's okay to start with 75 and then go on till 12 weeks. Do your 12-week screening using that 75. And if you still find her high risk, then escalate it to 150.
Yeah.
So that, you know, both parties are happy.
That will be a good algorithm, yes.
Yeah. Start off with 75 and assess the risk at 12 weeks. That's what we normally do as well.
Yes, that is what we do. I would like to use this forum to ask Dr. Chinmay. Many times we offer the APLA testing for everybody with who comes with 2 abortions. Hardly any, just 5% of the times the test comes positive. And usually what we have seen there, it's very difficult to repeat the test after 12 weeks. And sometimes when we repeat the test, again, the test is negative. So I have talked to my pathologist friend also, and he also says it's very difficult to pick up APLA.
So can I come in here? So there is, first of all, it's a very sensitive test because it has to be done in the conditions that the way the test has to be done are very stringent. And secondly, there is an entity called seronegative APLA. So even if the tests come negative and there's clinical evidence that this lady has had 2 miscarriages and is fitting into the APLA criteria, though the serology might be negative, even Catherine Nelson-Piercy says there is a role of empirical treatment of these women, though questionable, though not evidence-based. There is a role of treatment with aspirin and heparin. So something called seronegative, which we face a lot in our practice because it's very rarely we get the triple positive.
So seronegative, would you recommend both aspirin and heparin, or would you just go for aspirin?
It's just aspirin, not heparin.
Both. If it is seropositive, and yes, ma'am, Krishna ma'am.
Yeah, there are a few studies which have shown that even if it's seronegative, they have given both, but especially calling it unexplained pregnancy losses. But then it hasn't shown to be as effective as they expected. That's why I think without evidence. And one more thing is only even if it is seropositive also, even if you are giving both heparin and low molecular weight, heparin as well as aspirin, you are going to have only a 30% success rate of continuation of the pregnancy. Let us not presume that just because it's APLA positive and you're going to give aspirin and heparin, it is going to be 100% successful. That is the one thing I would like to bring in at this point. That's why people outside are trying to experiment with newer drugs for these people who are not responding to this particular medication. Now there have been studies where they have used hydroxychloroquine, they have used steroids, low-dose steroids, prednisolone, and immunoglobulins. These are the drugs which they are trying to use, and they have had good results when they used hydroxychloroquine 3 months before the pregnancy is planned. That's how they have shown good results.
Madam, I would just like to point out that the European Union for Rheumatology, they had said that even if we use the combination of aspirin and low molecular weight heparin, then definitely we are going to give good results to these patients. I use it for many of my patients, and the success rate goes up to almost 80 to 90%.
Many of them, if they're negative, they're also tested for ANA. And if that is positive, they start them on hydroxychloroquine.
ANA positive, right.
So I think one of the basic understandings that we have to have is it's the immunological cause which really takes the center. That is why hereditary thrombophilia versus acquired thrombophilia. So because the acquired thrombophilias have a higher immunological basis, and those are the ones who land up in this recurrent pregnancy loss. And so what the panel has come to a consensus is if it is a proven APLA, then you follow the guidelines and give anything between 75 and 100 milligrams. That is the guideline as of now, preconceptionally. So that is one of the MCQs that we had, that we have to start the aspirin preconceptionally and the heparin after the pregnancy test is positive. Not you don't need to wait for the cardiac activity or the gestational sac. So aspirin preconceptionally and heparin immediately as the pregnancy test is confirmed. And then because immunology is such an important thing, what is the role of immunological treatment for APLA, for recurrent pregnancy loss? I think all of you just need to give us a quick one-line answer. Yes, no.
Just before we move there, I just wanted to say a point that once in the pregnancy you diagnose as APLA, the next pregnancy you don't need to check again. You have to treat her from the beginning. So that is also an important. So history is also important. If the tests were done earlier and if she's labeled, you don't need to reconfirm that.
Yeah. Second, Dr. Chinmaya, the dose of low molecular weight heparin is the prophylactic dose which has to be used. And we only escalated to therapeutic doses if patient was treated with prophylactic doses of low molecular weight heparin in previous pregnancies for APLA, for recurrent pregnancy loss, and the outcome was not good. Then one can step up the dose to therapeutic, or if there was a history of thrombosis associated.
Previous thrombosis, definitely.
Yeah.
And if we are able to give a good result to her in this pregnancy, definitely she's going to come back to us only.
So what about immunotherapy?
No role.
Okay.
Madam just told us about hydroxychloroquine.
All in research settings, immunotherapy.
Sometimes it can be used, not often.
So in research settings, so immunoglobulins for specific indications. So like Dr. Vandana told us about this Rhesus isoimmunization. So somewhere that is where we use very high titers of ICT early on before the transfusion is possible. You may use, but that's a different pathway of recurrent pregnancy loss altogether. So infections.
Can infections? Yeah.
Anyone, what is your take on infections? Can infections cause recurrent pregnancy losses?
Infections do not cause. They never cause repeated pregnancy loss. They can cause a random abortion, not repeated.
So the TOG infections, we won't cause them. The only infections that are known to be associated with recurrent pregnancy losses are chlamydia and this ureaplasma ureolyticum. Potentially they have the thing, and suppose you have chronic endometritis like tuberculosis or something, for different reasons they might cause pregnancy losses, which may sometimes be repetitive. And the good thing about infections is they are treatable, although COVID gave us a different scenario altogether. But for other infections, we are a little more confident, and we think that with antibiotics, they can be
that still needs to be hammered, that we shouldn't be doing TOG testing for recurrent pregnancy loss as an absolute waste of money, and treated for IgG positives as well.
So I think, Dr. Sita, once we see the poll, we'll get an idea how many people still want to do TOG.
Do the TOG profile. and TOG profile is not completely out of the window because we do it for other indications.
Yes.
So when we do it for the valid indication, sometimes we get backlash that, oh, you're still doing TOG profile, but doing TOG profile for recurrent pregnancy loss is redundant. We did not do it. So, so immunological screening, any one of you wants to at least test for them?
No, madam.
We are in 2021, we want to do new things.
Other than the ANA, Sita madam said, other than that.
So all these fancy tests, nobody wants to do. Even if your patient has read this on the internet and asks you again and again.
Again, if she can afford, only for research settings, not for management purposes.
Yeah. I think that's a very clear message that the panel is giving, that if it's under research settings, then yes. Other sides, we have very little to justify that. And sometimes patients have all the money and they want to do all the testing. Then after doing also, there's very little that we can offer them based on these tests. So as of now, we don't recommend.
Yeah.
So,
so before you go for the closing this thing, I would like to ask one question on adenomyosis and recurrent pregnancy loss. Dr. Sangeeta?
Madam, I think treatment of adenomyosis is very tricky. And more than recurrent pregnancy loss, I think the patients of adenomyosis present more with infertility. So their issue is
implantation
how
failure.
To conceive.
Implantation.
And even if they conceive, you're right. I think many of them don't even are detected pregnant. They are only biochemical pregnancies. There are issues of implantation. And there is still a lot of work which we need to do for treatment of adenomyosis. For we do have no therapy so far for it.
And it is a continuum. It starts with infertility and implantation failure, but recurrent pregnancy losses, growth restrictions, prematurity, everything is quite common. And we have realized the importance of adenomyosis as a causative factor in pregnancy failure. We always used to think it was a disease of the little senior 40 at the 40s. So we were not.
Madam, I remember two young girls. One was 22 and another was, I think, just 24 or something. And it was very shocking that they had adenomyosis and the uterine sizes were almost 18 weeks and 22 weeks, which we had never read in books. We used to read that it never goes beyond 14 weeks. But when we had done a wedge resection, the report came out to be adenomyosis, and it was quite... so it is not unusual to see adenomyosis nowadays, and the people who are working in infertility can apprise us better about the incidence of adenomyosis.
That's the message I wanted to give even to the listeners, that when they have a recurrent pregnancy loss, it's, I think, mishaps which are repeating themselves, it's important that you also look into adenomyosis, come out of that typical class book description of 40 plus with 14-week size, secondary dysmenorrhea. It's gone. So quite a number of patients are positive, are adenomyosis, are having adenomyosis, and unexplained issues. Please look for that also. Okay, Chinmay.
Sure. Ma'am, there's some questions that audience have put, and I think we'll answer that before we go to the closing things. And
I think only one question we have before we close about progesterone. What do the unexplained infertility and what is the take of progesterone by our panelists? Do you give or you don't?
We definitely give it.
Speak the truth. You are under oath.
Yes, ma'am. Although literature does give lot of evidence and discourages the use of progesterone, I would not. I would at least be honest to confess that yes, at least one progesterone preparation we do start in these patients. But I have something more to add. My choice is between dydrogesterone or vaginal micronized after discussing with the patient. Because sometimes vaginal progesterone causes a lot of distress because of discharge. So patient's choice and comfort should also be taken into consideration. Number two, which I would take the opportunity in this span, please don't start the patient on multiple progesterones at one time.
Cocktail, progesterone
yes,
cocktail.
But some people try dydrogesterone
sequential. They will have everything. They will have vaginal, they will have intramuscular, they will have dydrogesterone oral micronized. So that practice should be totally discouraged.
No. Done. Multiple simultaneous progesterones, no. But what about sequential progesterones?
Sequential? Why?
Some people like to start with dydrogesterone because of its immunomodulatory property early on, and then
it can be continued up to 6 weeks. No issues if you want to.
They're using
converted to natural micronized progesterone, which has a better role in keeping the uterus quiet.
And then to avoid prematurity, convert into injectable progesterone. that will carry the pregnancy. It's a real sequential treatment.
So no sequential, no multiple at the same time. Whatever progesterone you choose one progesterone, talk to the patient and start that one.
Choose one progesterone means you have option between vaginal micronized and
dydrogesterone.
So I think Dr. Sangeeta, Dr. Sita.
Yes, we have studies. We have our own study by Dr. Ashok Kumar in 2014, which said that there is a role of dydrogesterone, and especially in our women, I think the acceptance of whatever all said and done, the acceptance of oral preparations are slightly better. So, because of whatever reasons, so I normally start them on dydrogesterone. The patient is compliant, then vaginal. So both have their sort of efficacy proven, moderate amount of evidence to show that they're effective.
So Dr. Sita, that Dr. Ashok's study was done right in Maulana Azad only.
Yes.
We, being the center, we support the use of at least one progesterone in these women.
Absolutely. Yeah.
Dr. Veena?
Yes, definitely one progesterone.
No, if you could ask the audience, all of them would say yes at this point, because I don't think any one of us doesn't give progesterone in a case of recurrent pregnancy loss. So, because that's something which, it's like all of us advising each other never to gossip, isn't it? We tell everybody never to gossip, tell our children never to gossip. But that's something we just can't do without accepting that. So for unexplained, these are things which are not recommended. The progesterone is something which is still in that evidence experience zone, and it has this thing. But other things like intralipid, endometrial scratching, the GCSF, we do not use in regular settings. And these, the lymphocyte immunization therapy, the IVIG, the glucocorticoids and heparin, currently not recommended in open clinical settings.
So you can questions, I think.
Yes, ma'am, because sometimes we have realized that doing nothing also should be an option in recurrent pregnancy loss, just because of that pressure of, offering something we need not offer. So there are some questions that the audience have.
The most important here is tender loving care and enough adequate time to all these women, adequate counseling and coming to that. Okay.
So thing is, ये हो गया blood का है. This is
The
RH.
questions, Chinmay, I think.
Yes, ma'am. I'm just saying. Yeah, this is Dr. Ankur Biswas from Kolkata. He's asked that, is it recommended to give Eltroxin in anti-TPO positive with euthyroid with history of RPL?
I think I've answered that there are studies. That's all. No evidence to say, but there are studies.
If it is hypothyroid, definitely treat. If it is euthyroid, then you need to take a call.
Even subclinical also they are recommending. Euthyroid is a query.
It can be considered, it said. Yeah.
Dr.
One more question. Yeah, go on.
Dr. Pratibha Arya says, we see high prolactin level at 12 weeks. What do we do? 12 weeks of pregnancy.
That's pregnancy.
Pregnancy
It's going to be high.
Pregnancy related prolactin, isn't it? So unless it's very high and you suspect a micro adenoma in the thyroid, get a physician to see that, unless it's in thousands.
Oh,
that is the case.
Evaluation. 12 weeks, unless there is, I mean, for what they have done, I didn't understand that.
Yeah, exactly. So Dr. Pratibha, I think the information here is you should know why you're doing that prolactin. If it's very mildly increased in the pregnancy level, that could be just normal for that stage of pregnancy. If it's extremely high, sometimes we get in thousands and all, and then we discover what is a microadenoma in the pituitary. So that would be a treatment by the neuro doctor, and she has to be referred there. So continuous night duty shift doctors have bad lifestyles and they may affect conception or not. Dr. Ankur Biswas has asked. Yes, absolutely. That all of us will vouch for the fact that not only software engineers, but also doctors are in that bad lifestyle group, which is why so many doctors visit the fertility centers now. So Dr. Harshiba Kaur from New Delhi has asked, what is the role of pericentric inversion of chromosome 9 in RPL? It's actually a normal variation. It's a normal variation, and that need not be, you need not worry about it. At which stage of workup we consider DNA fragmentation? Dr. Ankur Biswas.
Pregnancy loss itself is enough of a stage, I think. It depends on after counseling. If you still want to, you don't find any reason, then I think it's all individualized. There is no recommendation for when to do a DNA fragmentation.
So if you've done all the factors, the female factors are all negative and still there's recurrent pregnancy loss, you suspect that, then probably go ahead, but there's no recommendation. As such, the test itself is poorly recommended.
Yeah.
Please clarify. Yeah.
Or yes, maybe if the husband does not have a very good lifestyle, could be an indication.
If you're thinking strongly a male factor issue, please clarify the 12 weeks assessment before increasing the dose to 150. That's the first trimester screening for preeclampsia, where you do the nuchal translucency scan, the uterine artery Dopplers, PAPE and PLGF. And then if it is still high risk and you are on 75 because of this protocol, you can elevate it to 150. Since how much earlier should we give ecosprin? Yeah, that's a good question. How early preconceptionally has the ecosprin to be started?
Actually, nobody can tell when the patient is definitely going to be pregnant. And such a woman must be coming to you. She is desirous. So you should start her immediately once you diagnose her.
It's like folic acid. Yeah.
Premenstrually, we should say.
So Dr. Post-ovulatory luteal phase, we can start it.
So Dr. Indira from Hyderabad is asking, in case of APLA positive, heparin if started after pregnancy is positive, before viability, what should we do if it turns out to be ectopic? Well, check your stars, go to the astrologer, something is wrong.
Stop it.
Yeah, you have to
start the treatment of ectopic.
Stop.
Yeah, that is an extreme bad luck, and that's not how we
treatment. Go ahead with treating ectopic. Stop heparin.
Drop the heparin at the same time and then go ahead.
Yeah, so if she needs an ectopic management, she's going to have it under GA, so it shouldn't be a problem.
I think here for the audience, because we were just discussing this in the lighter side, there's no confusion here. Now you've started heparin and aspirin pretty early, and we understand that she is potentially in a poor coagulative state. If it does, how will it turn out to be ectopic if you don't see the sac? So this is a woman who's going to be constantly in follow-up with you.
Yeah.
So you will check the pregnancy test positive, and in the next week she will come with you to see the intrauterine sac. And if you don't see the intrauterine sac, and if you diagnose a ectopic that early at the level of
It will
checking
be
for
a
the sac,
medical management.
it's a very manageable ectopic. So let's not get all confused and carried away here that, okay, if we start heparin, there will be an ectopic blast there. It won't, because you are not going to leave this woman unseen for a long time. So even if it is an ectopic, it will be manageable. So this advice doesn't come very
yeah, most likely you can manage her with medical management.
If at all, yeah. So Dr. Revati Janakiram asks, progesterone SR oral preparation, same results as dihydrogesterone. I mean, the jury is out on progesterone. So she's suggesting taking the sustained release oral preparation in comparison to dihydrogesterone, which I think is fine. As such, progesterone is an individualized decision we discussed. So talk to your patient and give them
each one to their experiences.
Yes, ma'am. So doing nothing is also an option, is something which we should know, that because we don't really have an answer for what has to be done. And this is the guideline which says that you can advise them multivitamin supplements and just wait and watch also, because all the interventions that we have checked do not have a clear-cut role unless there is a cause which has been allocated. So if there is a uterine malformation and everything else is normal, then you know that that is the predominant cause. If there is a immunological factor, you know that is the predominant cause. If there is a genetic factor, that is. But if nothing is there, unexplained RPL, then probably do this. And these are all the things that have been we have gone through in this discussion. Madam, would you just like to summarize this part?
I think we have done enough. I think all the panelists have brought out all the points beautifully. We can skip these slides.
So before we complete, I think this is something extremely important for all of us to remember, that, you know, that tender loving care, which I think Dr. Sita was just referring to, is something which we should not undermine the impact of that. Because as it said, there is no foot too small that it cannot leave an imprint in this world. And this is a couple who've lost multiple pregnancies, and therefore the impact of that negative event is extremely strong, so much so that some of them may be actually going through proper PTSD and post-traumatic stress disorders, and we should identify that. So psychological support for these couples is of paramount importance. And therefore that brings us to another important issue. Is it a good idea to see patients with RPL in your general OPD every day when you have pregnant women waiting outside? What would the panel think about a proper conduct of a recurrent pregnancy loss clinic?
I think it's better to have a separate time so that we are able to devote a lot of time to her, so that she gets a patient hearing. She should feel happy that somebody is actually listening to her, trying to make her understand what could have gone wrong with that particular pregnancy, try to enlist what may be the probable cause which led to that pregnancy loss, offer her proper treatment management, and then still tell her that everything is not in our hands. We can do the best for her, so that I think she should feel satisfied at the end of the consultation. So she should have a separate time. Ideally, it would be better.
And once you take her history, you document it in a way so that every time when she comes, she doesn't have to repeat that history. That's another thing which is very painful for patients. So if we just document it once and for all, and we mark that file somewhere as RPL, then every time somebody will not keep asking her what happened. Yes. So that's one more thing. Sangeeta ma'am, you work in a government sector hospital, and do you think all this is possible in the government sector?
No, Chinmaya, to be very honest, you have visited us once or twice, and I hope you remember in the early days, 2007 and all, everybody was after my life. Why are you not doing first trimester NT scans in your OPD? And only once you got engaged with LBS in that project of growth, you realize what the scene is like. Yes, but we do have a fetal medicine clinic where the footfall is relatively for selected patients. So we at least have made it a protocol to divert this patient from the routine OPD to that clinic. And in a 3 hours clinic, there the number of patients is relatively less. So we are able to attend to them better. But this kind of a dedicated is still for us a dream come true.
And sometimes there might be a stigmatization also. Patients might not actually want to be in that clinic. So it works both ways, if you say that.
I think even in the private sector, it is not really, when it's far from that, where they can have a dedicated RPL clinic where, you know, so it's not always the ideal situation everywhere.
So what can we do? I mean,
but the
of
point
course-
is, yeah, even when you see them, it is important that you give them enough time, enough count, enough. You listen to them adequately, and then hear them out, and then don't be sort of judgmental and sort of come to a you let them express their thoughts and adequately counsel them as what. And a small thing here is, even when these patients get admitted after for any RPC or whatever, small things matter, as if it's possible to not to put them along with postpartum patients. A patient having an IUD or any for that matter, these small things are very, very traumatic for these. If it's possible to not put them along with these. So as you see them in the OPD, the same management goes in the patients as well.
And counseling is very important. For example, if you're stuck with a situation where she has to be next to a laboring woman or something like that, then you can go and talk to her and tell her that, this time your pregnancy didn't go well, but we are hoping one day you will be on that other side of the table. Just you give her some hope, give her something, and so that she develops a better mindset, and explain to her the thing. And when they come in the OPD, very many times we come and we are encountered where suddenly they come in a busy OPD, and you really don't have that much time that day. And then when they start opening one file after another, you realize it's a long story and it needs a long counseling. What we do is we tell them, leave a copy of your records here. Let's go through these records and we'll call you again and discuss everything with you. We keep the consultation pending, because they don't have to come and pay again for a consultation, but we tell them that we'll schedule a time for you and see you either before or after the OPD another day. And people accept it. They don't mind doing that, because it's something which they are also wanting a solution for, and we also need to allocate that time for that patient. So this whole concept of psychological support, I think, is very important. Krishna ma'am, your remarks.
Okay, so I think it was a wonderful panel. I think we have brought out the most important salient features of all the labs and treatment profiles. At the end of the day, I think what we have to remember is that we have to address the patient individually, personalized care with empathy, with tender loving care, look at all the risk factors, correct the behavioral issues, and probably do certain investigations which are very much in need, like looking at TSH, whether it is a uterine anomalies, and whether it is looking for acquired thrombophilias. These are easily done. If possible, go ahead with fetal karyotyping also. I would suggest from the POCs, then parental if necessary. Then again, we have simple treatments like supplementing with vitamins, progesterone, other than the specific treatments for unexplained infertility. Again, aspirin is again a big query in unexplained infertility. I think that is the basic, I think I have put it in a nutshell what all our panelists have been telling us in the last 1 hour. So we have to realize it is a recurrent problem, but we should not make mistakes, again, especially if they're not to make recurrent mistakes. And you made a recurrent spelling mistake. And we should do, and what we cannot do, we should not do. So first, remember, do no harm. And when necessary, if you like genetic counseling, fetal medicine, you should refer the patient to the right person and get a right answer for that patient. I think what we know is a drop, what we don't know is an ocean. Definitely, that is very, very true. And wish you all the best. And congratulations once again to Chinmayi. And I would like to thank all the panelists for the wonderful way they have presented their thoughts and their experiences. Thank you.
Thank you so much, ma'am, for holding this panel.
Because thank you, Krishna ma'am.
Thank you so much. Thank you, Chinmayi. Thank you, Krishna.
Thank you so much. I was really lucky to have such senior teachers and seniors to be here. And that brings us to the end of the academic session here. Nisha, do you have the answers of the quiz?
Yeah.
Yeah, ma'am. After today's enlightening session, I present to you the answers of the quiz. Ma'am, would you please share the screen, ma'am?
Waiting for the torch. Ma'am, I'm waiting for the torch answer.
Yes, ma'am. Yes, after such an enlightening session, madam, already the key is out, I should say. I'm just for the completion's sake, I'm giving you the answers.
But still, we would like to know what.
Yeah, just for the completion's sake, I would present the answers to you, and we would all love to know how the panel has answered, how the delegates have answered before the panel discussion. Next time, probably, ma'am, we should have a post test. So we'll have all 100% answers.
No, this time Jayam ma'am has told that this will happen, and I will hold the Science Integra people responsible for that. Jayam ma'am, you will help us next time.
So coming to the first question, which Krishna madam is waiting for the answer. Which of the following investigation is not relevant in case of recurrent pregnancy loss? The answer was torch profile, and now let us see how did we perform. So around 77.5%, that is close to 80% of them, wanted to do away with torch profile as an investigation for recurrent pregnancy.
Now it should be post this, it should be 100%.
100%. Yes, ma'am. Next question, Ashray defines, how does it define recurrent pregnancy loss? The correct answer was 2 or more consecutive pregnancy losses less than 24 weeks of gestation. And it's a 50-50. So around 45% of people gave the right answer as 2 or more consecutive pregnancy losses. The rest, probably it was the older definition which they remembered, 3 or more pregnancy.
No, they might not have thought of Ashray.
Yeah, they might not have thought of Ashray. Yes, ma'am. Next question. So chromosomal abnormality usually expected in a couple with history of recurrent pregnancy loss. The answer is a balanced translocation. And let's see, almost 2/3 of them answered it right, but balanced translocation, 66% of them gave the right answer.
And 23% were thinking of unbalanced translocation. Unbalanced won't be there in the adult.
Yeah. Right. So now we all know, after the panel discussion and so much discussion on genetics, now we know that with the history of recurrent pregnancy loss, the expected chromosomal abnormality is, ma'am, this is the previous one, ma'am, you'll have to go for the, in the products of conception is unbalanced translocation. And let's see, 50% gave the answer as balanced translocation. So probably they got confused between the couple and the product of conception.
Or simply went back. Check again. Did you go back to the previous?
No, ma'am.
No, it's just.
So the couple are expected to have, because the couple are normal individuals in society, their phenotype is normal. So they will have balanced translocation, whereas this POC is from a non-viable fetus. So this will be unbalanced translocation.
The right answer should be unbalanced translocation.
Unbalanced.
The last question, in a diagnosed case of Laplace with recurrent pregnancy loss, what is the most appropriate time to start low-dose aspirin and low molecular weight heparin? And now we know that aspirin has to be started before conception and low molecular weight heparin after confirmation of pregnancy, hoping that we do not have an ectopic pregnancy, as Madam said. And let's see how many of us answered it correctly. So almost 60% answered it right. Aspirin before conception and low molecular weight heparin after the pregnancy test comes positive. So with that, I come to an end of the quiz.
So thank you very much. Thank you, Nisha. And I think the only person that I have not introduced so far in our entire evening is Nisha. So Dr. Nisha Bhatia, she is from Hyderabad, and she was a gold medalist in OBG from the prestigious Osmania Medical College in 2010, completed her postgraduate diploma in clinical research in 2017. And she's presented this research paper of SDG to MDG5, India Marches Ahead in FIGO, Rio, Brazil, 2018. Has many publications, and I'm sure we'll see a lot of her as time goes by. She is Krishna ma'am's student and very proud faculty now at the Apollo Institute of Medical Sciences. Nisha, thank you very much.
Thank you, madam. And, I take this opportunity to thank you, to thank Shanta Kumari madam for giving me an opportunity.
So she did her duty yesterday so that she could be part of this program here today, and we really need enthusiastic people like you.
Thank you, madam, and especially thanking you because you made my first presentation, first job, very memorable. I'll always remember it and cherish it.
I hope you make more memories as time comes. So with that, we come to the end. I'm so glad Jayam madam is still here with us. Thank you so much, ma'am. Krishna ma'am. We need some words of blessings from both of us before we close. Ma'am, you're muted, ma'am. Jayam ma'am.
Yeah, excellent program. It doesn't look like a first program for you. It's very excellent, and the RPL panel with all the seniors, it's wonderful. And I wish Sita gets the same opportunity to conduct the first CM.
Thank you, madam.
to chair the session.
I will remember that, madam. Thank you so much.
Kumari madam was wonderful.
Blessings.
Yes,
Madam, blessings. It will work for you, Sita.
Thank you. Thank you so much.
Yeah. So we'll see you back again at the first CME in the next year in 2022 after October. Am I right?
Thank you. I hope so.
Wonderful, wonderful.
So all of you and to Nisha, my sweetie, who has done a very good work.
Thank you, madam. Thank you.
All
Thank
the
you.
best.
Thanks a lot,
Thank
ma'am.
you. And
Thank you very much, ma'am. Thank you.
So, just a formal vote of thanks for all the senior faculty and experts who have come here and graced the occasion. I thank Bharat Serum and Vaccines for supporting this entire project, and the team from Science Integra, especially Felicia, Mr. Seshan and Mr. Subramaniam, who have really given us a good technical logistic support here. And with this, I hope that we meet again and again in these platforms. So Bipin sir, are you still there? If you are there, you can just close the session for us. We had the president open it for us. We'll have the vice president close it for us.
Maybe he's not there.
No.
Yeah.
Okay.
Krishna ma'am, you please close it for us.
Yes.
I think I would like to once again wish you all the best, all of you youngsters, all the best in future, and a wonderful job, and keep going. And good luck to you, Chinmayi, for the next year.